Good morning, everyone. It gives me immense pleasure to welcome you all to this morning session, specially organized by ENT Ladies Forum. And this is a fourth session we are having. And before I go, I'm representing Microlabs Micro Knowledge Academy. I just would like to spend 1 minute on Microlabs before we go into our scientific of all the emerging markets. And also, obviously, it is approved by Drug Control Journal of India. And with regard to our quality, we have been regular recipient of quality awards regularly from all the association, including our Indian Drug Manufacturer Award. And also recently we got the Economic Award for Manufacturing Excellence. We have more than 23 divisions, which caters to different therapeutic segments. We have acute therapy, which includes ENT, and then all other specialty acute therapy, including critical care. And we have nephrology segment. We are very leading in diabetic segment and cardiology. We have neuropsychiatry. We have dermatology, 2 divisions dedicated to dermatology. So we are into all urology, the recent addition. So we have into all the therapeutic segment catering to the all therapeutic segment formulation except in oncology. With regard to our academic initiative, we do an academic initiative under the Micro Knowledge Academy. We have a dedicated e-library. I request any one of you, it's open to all doctors. You just have to log in. We have the set of slides, all CME slides arranged therapy-wise. You can download and use them. All therapy guidelines are available at the fingertip and latest medical update. And then a lot of patient education material you can download and share it with your patients, and latest newsletters are available. Books are available for download. So you can log on to www.microlabselibrary.com, or our representative will give you a QR code by which you can log in. And also there we have divided even for nurses, because we do a lot of activities for nurses, and nurses also can be downloaded. Their education material slides are available to them. And ours is another flagship activity is Fever Foundation. We do a lot of research on fever under Fever Research Academy. And we do national and international conference. Actually, we have done 5 national conferences. This we had we had the record number of 36,000 doctors logged on to it. We have Government of India representative talking, or Dr. N.K. Arora talking on vaccination update. And we have WHO representatives coming and talking about various aspects of COVID, and all other top doctors from medical college. And we also did poster presentation last time from postgraduates for medicine and PGs. We received 150 posters. Our medical college professor helped in evaluating. That is about Fever Foundation. And end-to-end workshop we do every year, live surgery workshop. Thanks to Dr. Deepak Haldipur sir and Dr. Vishwas who are guiding us, and madam who are guiding us to this activity. We do the live surgery workshop for all ENTs. Hypertension Foundation is where we do research under foundation. We maintain the Hypertension Registry of India, and also we are starting this year in-home BP monitoring to check whether if the patient checks regularly blood pressure at home, will it give a better kind of management rather than coming to office or hospital and getting his check. This study is starting next month, so we'll come to the results of that. And we also are leading in the under ADF Diabetic Foundation. We do a lot of activity, diabetic research detection camps. We do neuropathy detection camp, HbA1c camps. It's a regular activity we do this. And then lipid registry this year will be starting. Pranam and Pranad is our 2 activity which do encouraging PGs to publish their papers, we help them in writing, paper writing, and lot of things. Or some of the practitioners who have no time to write the article, we help them in manuscript writing, such kind of Pranam. In their data, we help them in medical writing activities. So these are some of the academic initiatives. And in our Bangalore ENT Forum is one such activity. Thanks to Madam Lakshmi Madam and Dr. Tara and Dr. Mai, who all helped us in formation of this. And I'm happy to say this is the 4th time we are having, though because of COVID, otherwise it would have been 6, right, ma'am? First meeting we had about 7 to 8 ladies, and under guidance of Dr. Lakshmi ma'am, we had the first meeting where madam spoke about secretory otitis media. The second meeting we had in a place called Madhuman, very nice natural resort as well as an organic farm, where we had that we had dedicated to phonosurgery. It was more of a larynx. We have Dr. Gauri Kapre came in and talking about voice surgeries. Then last meeting we had in the same place, where the third meeting, it was dedicated to sleep apnea. Dr. Suma, pulmonologist, came, and maxillofacial surgeries, right? So after 2 years, we could not do because of COVID, and we are again back here. Today, we are dedicating it to allergy and facial plastic surgery. So this is in nutshell. And before I close, I just request all of you to, though we have done 4 meetings, we wanted to take it to the next level. If you all give us some new ideas, something madam already has few ideas which she is telling, and so that we can take it to the next level and we can expand and do a lot of other activity under ladies forum. So this is some of the snippets of what we did earlier, few meetings and the sessions, and you can see madam here and Dr. Gauri Kapre, and these are first meeting, group meetings, and these are the things which we had done earlier, just to show the earlier photo, nostalgic things. Okay. So today we are back again with a very, very high content scientific activities. And then it is led by Madam Lakshmi Satish. So without why am I wasting much time? I have the pleasure and privilege of introducing Madam Lakshmi Satish, who doesn't require any introduction, but I am, as a formality, I'll be doing. So Madam is a senior consultant ENT surgeon at Sagar Hospital, Jayanagar, and also she is director and consultant at her own place, Cosmetic and ENT Care Center, Bangalore. And she also goes as consultant at Excel Care Hospital and at also Apollo Spectra Hospital. And she's been an honorary consultant at Indira Gandhi Institute of Child Health, at Nimhans and St. Martha's. And she had done ODTC training at Royal Hospital. And she's been the faculty at MS Ramaya. And she has published several papers in peer-reviewed journals. She gives a lot of activity, very popular TV kind of personality. She's on TV, especially COVID time. She was there helping people how to manage, how to go, and a lot of things, including she spoke on vaccinations, everything, every aspect she spoken during COVID. And currently she is the governing council member of Association of Otorhinologists of India, and she was the honorary president of Bangalore branch and honorary treasurer of Bangalore branch. She has several awards and accolades to her credits, and just to name a few because of the paucity of time, she has Vidya Ratna Award from the Lions Club and Karnataka Seva Mitra Award from Lions Club and gold medalist from our college, Bangalore Medical College. And she's been really helping us in a lot of scientific activity. To personally, I'll trouble her anytime, madam, what to do this, anytime. She will patiently tell, and she will follow up by everything. Last night also, 11 o'clock, she's telling how things are going very well. So she is guiding force us for Women's Forum and all our scientific activity. May I request Dr. Lakshmi Satish to come here and take over. Thank you very much.
Good morning, everybody. At the outset, I would like to welcome all of you for today's fourth meeting of Bangalore Women's ENT Forum. It's been my pride and privilege to have excellent speaker, international speaker, Dr. P.K. Vedanthan and Srimati Kamala Vedanthan with us today. We have eminent facial plastic surgeon, Dr. Shruti Marwa, who is going to join us online, and Dr. Vishwas Vijay Dev as the main speakers for today. And we also have a session on mind and meditation by Mrs. Sahana Satish, who will be joining us soon. And I welcome you all and enjoy and take part in the scientific session and sit back and relax. At the outset, I would like to congratulate and thank Mr. late G.C. Surana, who is the founder of Microlabs, this great company which has grown in leaps and bounds in the last 2.5 to 3 decades. Mr. G.C. Surana is no more with us, but his sons, Mr. Dilip Surana and Anand Surana, have taken over this company, and it has taken to a altogether different level. They are very well known for their philanthropic activities. They are very well grounded, extremely simple human beings who have to be emulated. They have certain role models themselves as examples. Okay, their humanitarian activities and their constant solid support for all academic activities should be acknowledged and thanked. So I would like to dedicate this CME program to late Mr. G.C. Surana. So let me introduce Dr. Shruti Marwa. She is an ENT surgeon. She has done her MBBS from Maulana Azad Medical College and MS ENT from University College of Medical Sciences, New Delhi. She's a facial plastic surgeon with an MCH from All India Institute of Medical Sciences. Currently, she's practicing as a facial plastic and aesthetic surgeon at Honda Aesthetics and Plastics. Though she is very young, she has accomplished a lot. The main focus of this forum is to encourage and support young upcoming lady ENT surgeons, because we already have about 150 plus lady ENT surgeons in Bangalore itself. Though we do not want to dissociate from the main group, this platform is just to give little extra encouragement for the ladies who are growing in leaps and bounds in number and also doing a fantastic work. So we do have a lot of stalwarts in our field, and Shruti Marwa is one among them. She's unable to join us physically for the conference because of her advanced pregnancy. So she'll be delivering a lecture on scope of facial plastic surgery for the upcoming ENT surgeons. So can look up to this specialty as one area of super specialization. Otolaryngology has been a fantastic field. It was earlier restricted to few surgeries. 3 decades ago, when myself, Deepak, Dr. Bharti, we are all contemporaries. When we all did our MS, the training in the medical colleges in Karnataka at least was not all that great. We had a large number of fantastic variety of cases. We were exposed to all kinds of diseases, which nobody would else dream of seeing. But the surgical expertise was not focused on super specialty training. We didn't have access to great microscopes. Endoscopic sinus surgery was just evolving. So we were left with a good sound theoretical clinical knowledge and few basic surgical skills. So all our learning happened after we passed out of MS. There was no fellowship at that time. So if we were interested in otology, we will go and mentor ourselves, take mentorship from Professor Dr. Mahadevaya, or we would go to Bombay and get trained. Like that, we would go and work with different doctors to gain knowledge. So continuously, the learning curve has been happening. Bombay was an excellent place of excellence for surgical learning in otology and in endoscopic sinus surgery. So a few months I went to Bombay and trained myself with Dr. Kirtane. Then I worked with Dr. Mahadevaya for a few months. And likewise, we grew in different specialties by observing and practicing on the bones and on the cadavers. Like that, we have grown in our specialty. Today, otolaryngology has expanded so much that the ENT surgeon is reaching the skull base and beyond into the cranial cavity with their endoscopes, and they're doing fantastic, phenomenal surgeries. And Dr. Deepak Kaldipur is a living example of a fantastic skull base surgeon. Okay, so, and he's also a otologist. He's multifaceted and multi-talented. So we have individuals who are super specializing, the youngsters especially. They are very lucky today because they have a lot of CME programs. There are so many mentors, and they get a lot of guidance where to go, what to do and what not to do. So that way, they're early in their life itself, they can focus on one subspecialty and grow in that specialty. Instead of working as an observer or for a few days, few weeks, few months, you have a full year of training. This platform is going to give an eye-opener in the specialty of facial plastic surgery and also allergy and immunology. Allergy and immunology has grown tremendously, and we have the world famous leader, the founder of Allergy Asthma Institutes, International Asthma Society and all, Dr. P.K. Vedantan, who is with us. We are fortunate to have him today, and give him a good round of applause and welcome him also. So when such is the opportunity for ENT surgeons, we have to explore, we have to see which specialty we are interested in and move forwards in that direction. I hope the youngsters will get a encouragement from Dr. Shruti's talk, and some of you will be able to take up this specialty. Over to Dr. Shruti, please.
Thank you, ma'am.
Yeah.
A wonderful introduction. I hope everybody can hear me.
I request Dr. Vishwas to moderate this session with Dr. Shruti.
Good morning, everyone. Thank you, Lakshmi ma'am, for a wonderful introduction, and thank you to Dr. Vishwas for helping me present some of my work and my views in this wonderful CME today. The topic of my presentation is scope of facial plastic surgery as a subspecialty for budding ENT surgeons.
Hello. Dr. Shruti?
Yes, sir.
Yeah, very good morning, and thanks for joining in today.
Thank you so much.
There's a full house waiting to listen to you. I think without much delay, we'll have your presentation.
Right, sir. So these are some of my credentials. Right now, I'm working as an aesthetic plastic surgeon at Honda Aesthetics and Plastics in New Delhi. I'll be presenting most of my work and some of my own views on how to progress if you're looking to become a facial plastic surgeon after ENT. Okay, so the first thing that many of us might know or not know is that the father of modern plastic surgery was Sir Harold Gillies. He was an ENT surgeon and otorhinolaryngologist himself. He was one of the pioneers who had started doing facial reconstructive procedures in, patients and soldiers from World War I and II. So if anybody is looking for inspiration, it is right here. In fact, this is what I read in my ENT book, Cotton Brown, first time. And that is when I realized, okay, fine, that's a lot of motivation for any ENT surgeon who want to be associated with the field of plastic surgery. Facial plastic surgery is a wide branch. We cannot limit ourselves by just calling ourselves a facial plastic surgeon. It can range from aesthetic surgeries to malignancy treatments, skincare regimens. I'll go ahead and explain everything as much as possible. Congenital anomalies, reconstruction of scalp, forehead, cheek with local flaps, free flaps, reconstruction of eyelid, nasal reconstruction ranging from local flaps, forehead flap to total free flaps, facial palsy management, orthognathic surgeries, and even burn and wound management. So when I show you this gamut, what I mean to say is that we have to choose. Even after ENT, if we go into the field of facial plastic surgery, you will have to choose one of these specialities, one of these super specialities, and then excel in that, because we don't want that we become a jack of all trades and master of none, especially in today's environment where everybody is doing fellowships and becoming better and better in their field. So in my opinion, when I started after researching about plastic surgery after my MS, I could think about two major fields. One was to go for an MCH and the other was fellowships. This is my opinion. Maybe people will differ from it. They might have something more to add to it. But what my research told me was that if I go for MCH, I will have the advantage of knowing the basics of general plastic surgery like flaps and wound management and burns management. But it is definitely a longer route. You would have to, see patients with wrist cut injuries, traumas, burns, something you would not be doing as a facial plastic surgeon ever in your life. So it is definitely more complicated than that. Despite doing an MCH, if you plan to go further into a particular field like aesthetics or craniofacial or other oncological reconstructions, you may still need fellowships. But one big advantage is that in an aesthetic practice, cosmetic surgeries are holistic. If you know how to transfer a fat or harvest a fat by liposuction or harvest a rib cartilage, you will be much more confident in what you are going to do in your patient. Fellowships, on the other hand, are definitely more direct and shorter, can range from 3 weeks to 6 months to 1 year. It might or might not improve your confidence in that particular field as long as you're clear in your head what you want to do. I think fellowships are a very good way. There are different areas of fellowships like craniofacial, cosmetics, oncological. So at the outset, you have to choose where you want to enter rather than being confused and thinking which particular area to choose. Like if you're going for aesthetics, then you are going to do an aesthetic fellowship and then excel in that alone and not do oncological reconstruction. One important point that came to my mind was that management of complications. As long as everything is going well, it's great. But for example, if you end up with a skin flap necrosis after your rhinoplasty or a facelift surgery, would you know how to manage these areas without a very intensive exposure to management of wounds and trauma and all these things without a degree? I am not sure. I'm sure people who have done fellowships, they can answer this question better. And again, once you're doing a fellowship, we cannot touch the body because we are, as ENT surgeons, going to concentrate on the head and neck area, which is, I think, fair enough, and we are more than capable to do that. Now, if you foray into an aesthetic practice, these are some of the procedures that you will be looking at: rhinoplasties, facelifts, eyelid surgeries, chin implants, dimple creation, jawline contourings, fat grafting, and a lot of non-surgical procedures as well. These are some of my results. Just wanted to show you that after ENT, I personally believe that an ENT surgeon is very well adept into foraying into the aesthetic field. We are the masters of the head and neck, and we know what to do and what not to do in most of the areas. Some points I'll tell you, which I think that we lack in our ENT training. So maybe for those, you can go for a fellowship or observership and observe people who have pioneered in those fields. An example of a reduction rhinoplasty, augmentation rhinoplasties, facelift, pro lift and neck lift, dimple creation, a very short and a very gratifying procedure in aesthetic patients, upper blepharoplasty, lower blepharoplasty for eye bag removal. Okay, this slide I've only put to show that sometimes we are not exposed to the anatomy of the eyelid. And when we go into the field of aesthetics, blepharoplasty is a very, very important topic, a very commonly done procedure, very, very easily done procedure, as long as we are aware of the anatomy. Again, liposuction, if you're restricting ourselves to the face and the jawline, again, a very gratifying procedure. But yes, we need to understand its basics. We need to understand how it is performed and the various technologies involved. Some examples of chin surgeries like implants and genioplasties, very, very much within the foray of an ENT surgeon. And I believe that we can do a wonderful job because we are exposed to these areas very frequently. This is an example of a girl who has something known as a Parry-Romberg syndrome, where you can see that half of her face is already atrophied since birth, and it is a disease that progresses during the first years of the life, and then it becomes static. Now, somebody who has such a severe differentiation between both the sides of her face will either require two of these procedures, or fat grafting or a free flap. I have put this slide only to show you that because it's a case of the face, the patient is very likely to turn up to an ENT surgeon. Fat grafting, harvesting of the fat, how to perform it, I believe that can only be understood or learned once you have done a fellowship or observership at the right place under the right surgeon. A free flap will be out of the realm of an ENT surgeon, but we should be aware that these options are there. What we offer to the patient depends on what we can do or what we are trained in. Cyst excisions, scar revisions, very frequently we have done in our residency. We see these cases very frequently, nothing great. Non-invasive procedures like lasers, Botox, fillers, a very important part of aesthetic practice. Again, people are turning into cosmetologists. There are even doctors who are not even only MBBS doctors. People who are not even doctors are doing these procedures so frequently nowadays that I believe as MSCNTs, as surgeons, we are more than capable of doing these procedures, learning their basics and adding that to an aesthetic practice. Example of Botox injection. Okay, this is the aesthetic part of a facial plastic surgery practice. Now what I'll be speaking about is the rest of the facial plastic surgery. These are the two very basic books that we learn from in plastic surgery MCH, Grabman, Smith and Nelligan, and some of the pictures I've taken from these books to drive across my point. Congenital anomalies like cleft lip and cleft palate, again, very frequently will be coming to an ENT surgeon as well. They are difficult to do. The children are small. These children require multiple procedures at different stages of their lives. Sometimes you will have to involve an interdisciplinary team with an orthodontist, with a plastic surgeon, with a speech therapist, with a child psychologist. I would suggest to perform these procedures either with a team or in an institutional setup. But just the surgical part, the cleft lip, cleft palate, orthognathic surgeries, I believe that if you are well trained, these are surgeries that can easily be done by an ENT surgeon. Vascular anomalies, this is an example of an infantile hemangioma, but the vascular anomalies is again a vast array of anomalies that the child can come up with. How to manage them? It's pretty straightforward. Mostly it's a medical or a interventional radiologist's management. Sometimes requires surgeries. As long as you know our basics, it should not be a problem. Craniosynostosis syndromes are another completely different gamut of area. These are syndromes which obviously means that not only the head and neck, the other parts of the body are also involved. So again, an interdisciplinary approach is required. You need the help of a neurosurgeon. Sometimes their hands will be involved, sometimes their legs will be involved. You need to identify the syndromes. So in my opinion, to foray into this field, one needs a good 1-year craniofacial fellowship and an interdisciplinary approach, which means that probably an institutional setup where the child can be treated in a holistic manner. Again, some of the examples of the syndromes, as you can see, the other parts of the body, like the hand and the sometimes the airway is involved, sometimes the heart is involved. So the syndrome has to be treated as a syndrome and not as an isolated head and neck case. It will require an interdisciplinary approach. An example of a child with golden heart syndrome, with anosmia, with the drooping of the lower lip. So these things can be very well treated surgically by an ENT surgeon, but again, the syndrome has to be identified. This is an example of a craniofacial microsomia where half of the face is not well developed, is partially developed. This is an example of the treatment that it requires, which is distraction osteogenesis. Again, solely and wholly in the realm of a head and neck surgeon or a facial plastic surgeon. But you need to understand the methods of bone conduction, the methods of bone healing. And again, as long as your concepts are clear, you are trained into this procedure, it should not be a problem. Orthognathic surgery, an example of a female with a microgenia with a small mandible. Nowadays, with advancements in technology, we need to be adept with something known as the CAD/CAM, that is computer aided design and computer aided manufacturing. This is an example of cutting guides that have been used to advance the chin, also known as a genioplasty. Orthognathic surgeries can be very gratifying. It's an area where everybody has forayed into, ranging from a maxillofacial surgeon to a plastic surgeon to an ENT surgeon. But you need to understand that if you are aware of the basics, only then we can enter into this field. Maxillofacial trauma, everybody gets it. As I said, in a private practice, a maxillofacial trauma will be seen by somewhere by a maxillofacial surgeon, somewhere by an orthognathic surgeon, somewhere by a plastic surgeon, somewhere by an ENT surgeon. The basics are pretty clear in these areas. You need to understand how to plate, when to operate, when not to operate, the post-op. But again, it should be not relatively very difficult because, as I said, the anatomy is clear to us. Ear reconstruction. The most important thing about ear reconstruction is that when we see a child with hearing loss, and if they have anosmia, microtia, any kind of ear deformity, first person that the parents take to the child to is an ENT surgeon. Unfortunately, as far as I am aware, we are not doing a lot of ear reconstructions, which should totally and wholly be done by an ENT surgeon, primarily because it is totally our realm and we are aware more than anybody else how to treat this area, and we know the anatomy very well. There are only two things that I feel the ENT surgeon should be trained in before they embark on the journey of an ear reconstruction. Temporalis fascia harvest, a very important part of an ear reconstruction. Who would know the anatomy of temporalis fascia better than us? It's just the flap part that needs to be understood and be trained in. The second point is very important, obviously, rib harvest. Now, I don't believe that you need to take a 6-month or a 1-year fellowship to understand how to harvest the rib. I believe that if you are going to the right person, to how to harvest a rib should be something that you can learn in an observership of probably 2 weeks. The second important point is how to carve the ear and how to make it look as natural as possible. And the carving technique, again, you can learn in an observership or maybe a short fellowship. But personally, I believe that ear reconstruction should be totally done by ENT surgeons. There is no reason for referring the child or calling a plastic surgeon for these procedures once you are adequately trained into the harvest of the rib and carving of the rib cartilage. Small ear reconstruction procedures like lobule reconstruction, bat ear, prominent ear management, again, totally in our realm. Who would know the anatomy of the ear better than us, of the external ear? Facial palsy. This is a patient courtesy Dr. Vishwas who had referred her to me. Okay, this is a list of the surgeries or the procedures that can be offered to a child or a adult with facial palsy. If you read through it carefully, there is nothing that is outside the realm of the head and neck surgeon or the head and neck arena, except for a microvascular transfer. Point being that when the facial palsy patient comes to us, and we are the masters of facial nerve, we know how to, we know the path of facial nerve right from the brainstem till the lower motor neuron area. So any of these procedures, once we are well trained, we should be able to perform in a patient with grade 5, grade 6 facial palsy, except for obviously the microvascular transfer, which will require higher level training and cannot be done routinely. So facial palsy management, again, wholly and solely in our realm. These are some examples of post-oncological or traumatic reconstructions. This was a patient who had come to us with nasal trauma. He had a very big soft tissue defect on his nose. We performed a forehead flap, and this is right before he went for his second stage and also for a lip asymmetry correction. Okay, this is example of a free fibula flap where we take the fibula and we reconstruct it to maintain the integrity of the of the mandible. The picture of a specimen that was taken out. This is the intraoperative picture where the entire carcinoma was resected with good margins. And you can see this is the fibula bone that was attached to the anterior and the posterior part of the mandible. This is the result at about 3 months. Obviously, the point being that I'm not saying that we can do a free flap right from the set go. But if we are well trained into microvascular anastomosis, at least we should be aware that which is the case that will require a local flap and which is the case that may require a free flap. And there is no harm and there is no shame in involving your plastic surgeon and doing it together with them. In fact, in countries like US and UK, the ENT surgeons undergo 1-year fellowships to understand and how to perform the free flaps, and they perform their own free flaps. They do not involve people from other specialities to do any kind of reconstruction, something that we can think about. But again, a case like this will require an institutional setup, a multidisciplinary team, and as well as a critical care management. This is a short video to show you how a microvascular anastomosis is done. Microvascular anastomosis fellowships and observerships are very short. Just understanding the anastomosis will take you probably 10 days of training, which is not much. But obviously, if we are venturing out of the area of the head and neck and going into the leg or the arm to take out flaps, we need a longer and a much more intensive training. Ptosis correction, an example of a patient with severe ptosis who had undergone a frontalis sling operation. We had harvested the tensor fascia lata, and this is the
Dr.
result at
Shruti?
1 month. Yes, sir.
We're not seeing the screen. Just give us a second.
Right.
Tell the attendees here how the training process is for 3 years. Maybe they'll understand. Yeah, now we are back with you anyway. We can see your screen, Dr. Shruti.
Okay, sir. So, what was the last slide that we could see? We saw the video, I hope. The anastomosis video.
Now we are seeing it.
Okay. So just to give you an idea how a microvascular anastomosis is done, as I said, the training of microvascular anastomosis takes probably about 10 days. But obviously, to venture out of the area of head and neck and try harvesting free flaps on the arm and the leg will require a lot of intensive training and probably a fellowship of not less than a year. This is an example of a young male who had undergone a frontalis sling operation for severe ptosis, results at 1 month. The frontalis sling was created by the tensor fascia lata, which we harvested from the leg, which is the harvest of a TFL is also a pretty straightforward procedure, but again, we need to be a little trained in it. An example of a local flap with grafting done for a scalp and a forehead defect. I believe that Dr. Vishwas will be presenting more about local flaps, so I'm not going to go into the details, but definitely a procedure that should be part of our armamentarium because defects come to you very, very frequently, especially people with post-oncological and post-traumatic reconstruction. Burns and wound management, a very small part of facial plastic surgery because it is very rare to have a patient who would have extensive facial burns and not have other parts of the body involved. However, you need to know the degrees of the burn and how to identify them, which is very important. That is how you will decide the management of burns. An example of a lady with second-degree superficial burns and how we treated them. These are examples of patients with chronic burns, a patient with a band in the neck, an extrinsic contracture, an intrinsic contracture. These can be seen frequently by head and neck surgeon as well, as long as other areas of the body are not involved. All in all, we can get these patients anytime at any point in our practice if we are practicing as a facial plastic surgeon. Yes, if the patient is coming with an inhalational injury, as obviously who would know better how to manage the airway injuries and manage the airway better than an ENT surgeon. We can do anything from intubations to tracheostomies to whatever is required. But a patient with inhalational injury will also require a critical care management. These patients are very, very sensitive. They are usually not in a good, they do not come conscious oriented and all those things. So management of burns only possible if you are in an institutional setup. But yes, chronic burns, we should know how to treat, how to do grafting, how to treat ectropions. Again, very well within the realm of a facial plastic surgery. How to manage burns? This is a ladder that we learn in plastic surgery, MCH. We need to know types of dressings. There are 100 types of dressings that can be used, each with its own advantages and disadvantages. Primary repair, how to take a graft, how to take a full thickness graft, and local flaps. This is something that can be learned and executed very well in our daily practice. Of course, regional flaps and free flaps require a lot of intensive training, as I said, but we need to know when to stop. We need to know when to refer the patient to the right surgeon rather than keeping on, dressing them and making them suffer or something like that. Because we get a lot of patients like these who are coming from places where they were not being treated very well because the treating surgeon or the treating doctor did not know what to do. So if the training or the information or the knowledge is adequate, it should not be a problem. Last but not the least, face transplant. There has not been any face transplant in our country yet. There have been cases of hand transplant in many areas like Bombay, Kochi, Stanley Medical College. It is the ultimate of a facial plastic surgeon that one can achieve. What we need to know as an ENT surgeon or as a facial plastic surgeon is we need to know the microvascular anastomosis technique. And actually, that's just about it. The entire anatomy, right from the scalp to the neck, where to find the vessels, and everything is something that we are very, very adequately trained into. So why can't an ENT surgeon come ahead and do a face transplant if they have been adequately trained into the field of microvascular anastomosis? I don't see any reason. So it should, before it comes from a plastic surgeon, it can also come from an ENT surgeon. In the end, these are the main three areas where fellowships are offered to people who want to foray into the field of facial plastic surgery. In India, maybe not so much, mostly in other countries: aesthetic surgery, post-oncological reconstruction, orthognathic surgery, and last I would say would be a craniofacial surgery, craniofacial fellowships. So if you are looking to foray into any of these fields, research well, find the areas that you want to go into, and then choose the right fellowship. My final message would be that qualification and experience matters. In today's litigious environment, we need to be coming from a place where we have gained the right degrees, gained the right knowledge and experience, and we know what we are getting ourselves into. Choose your specialization. As I said, even as a facial plastic surgeon, you will not be again, jack of all trades and master of none. You will have to specialize further. You'll have to choose. So if you're clear in your head which field you want to go into, whether it's aesthetics or oncorecon or whatever, then you will have a better chance at being successful and being an expert in that field. Know when to operate. Once you have been trained well, you will obviously know when to operate, what to do. Especially know when not to operate, because there will definitely come a time where as an aesthetic surgeon, as an oncology surgeon, as somebody who is doing local flaps, you would come and say that this is not something that I am comfortable in doing, or maybe there is a complication and you have to go outside the field of head and neck and maybe harvest a DP flap or maybe a free flap. So then involve your colleagues who are equally or better trained, involve your seniors. And there is no shame in involving other qualified plastic surgeons, senior surgeons, who can help you and help you manage the case, or who can do a better job maybe. In again, last point is, in today's environment, there is no scope of being average, especially if you're in the field of private practice. You have to excel in what you do. So even after ENT, if you're wanting to become a facial plastic surgeon, I would say once you've chosen the subspecialization, in my opinion, just practice that. If we start, if a general surgeon starts practicing laparoscopic hernia repair along with a free flap, he's not going to excel in either of them. So I believe that same goes for us. We need to be, masters of our field, and only then we will be able to achieve better than what people are doing in the daily practice, like what plastic surgeons are doing as facial plastic surgeons. That's it. Thank you.
Thank you, Dr. Shruti. There's been a big round of applause for you. And you've comprehensively taken everybody through how our training is and how to improvise on our skill set, and also involve the team and the various branches of facial plastic surgery itself. And thanks for encouraging the crowd here. I'm sure some of us here will be encouraged to pick up facial plastic surgery in the future. Okay, if there's no questions, we will give the audience your contact number if it's okay with you.
Absolutely, sir. I'll be happy to find somebody who wants to become a plastic surgeon after my lecture.
Yeah, thank you. Thanks for coming in. I'm sure we would have had you here if it was not for the pregnancy. Next time we'll meet you in Bangalore.
Absolutely, sir. Thank you for inviting me.
I'll just hand over the mic to Dr. Lakshmi.
Thanks a lot, Dr. Shruti, for a very informative and insightful lecture on facial plastic surgery. I'm sure some of the younger colleagues will be definitely motivated and take up this specialty as their career. Thank you very much. And in the end of the session, we will share your number. Whoever wants to connect with her will contact you.
Absolutely. Thank you, ma'am.
We are slightly changing the schedule of the lectures. Now we will have Dr. Professor P.K. Vedantan's lecture. I'll have the pleasure of introducing him to the audience. We'll have the invocation song by Srimati Kamala Vedantan now. Madam Kamala Vedantan, she's the brain behind and the moral support, physical support, everything behind Professor P.K. Vedantan, sir. And she's rightfully his Ardhangi. She's an accomplished musician, and she also is an accomplished allergy technician. She does, I've seen in all his videos, she doing the allergy skin prick test and counseling the patients. Over to you, madam.
Thank you very much. As they say, there is no beginning or the end for life cycle. Like that, we changed the program a little bit. We started off with the lectures and stuff, and then they said to go with the invocation. It doesn't matter. Okay, so I will sing a little song written by Brahmananda ji. It says Jai Ganesh Gananath Dayanidha. So it's on the Lord Ganesh to bless the occasion here, and good luck for all the future patients and the current patients that are going through all these turmoil in their lives, including my own family, my two sisters and daughter-in-law. They went through a couple of surgeries just yesterday and day before yesterday. So I just wish everybody all the best in life. Okay. Jaya Ganesh Gananath Dayanidhe. Jaya Ganesh Gananath Dayanidhe. Sakala Vighan Kar dur Hamare. Jaya Ganesh Gananath Dayanidhe. Sakala Vighan Kar dur Hamare. Jaya Ganesha Gananath Dayanidhe. प्रथम करे जो ध्यान तुम्हारा, प्रथम करे जो ध्यान तुम्हारा, किसके पूर्ण कारज सारे। प्रथम करे जो ध्यान तुम्हारो, किसके पूर्ण कारज सारे। जय गणेश गणनाथ दयानिधे सकल विघ्न कर दूर हमारे जय गणेश गणेश ब्रह्मादिक सुर ध्यावत मन में ब्रह्मादिक सुर ध्यावत मन में ऋषि मुनि गण सब दास तुम्हारो ब्रह्मानंद सहाय करो नित ब्रह्मानंद सहाय करो नित भक्त जनों के तुम रखवारे भक्त जनों के तुम रखवारे जय गणेश गणनाथ दयानिधे सकल विघ्न कर दूर हमारे जय गणेश गणनाथ गणनाथ दयानिधे. Thank you.
Excellent, madam. Thanks for invoking Lord Ganapati for our CME program. Now I have the pleasure of introducing Professor P.K. Vedantan. He's a world-known allergy specialist, and he's the founder of International Asthma Services, and he hails from the University of Colorado, USA. Professor is from Mysore Medical College. He has done his MBBS in the year 1969. Later on, he moved to the US to do his internship, and later on his residency in pediatrics from Rhode Island University. Later on, he went on to do his fellowship in allergy, asthma, and immunology from the National Asthma Center Denver, Colorado. That's where he settled subsequently. He is the founder of IAS, that is International Asthma Services. It is dedicated to improve the overall care of the asthma patients around the globe and to educate patients, their families, as well as the motivated patients. To facilitate technology transfer, International Asthma Services, IAS, it is active in India, Kenya, Myanmar, Fiji, Philippines, and in many more countries, including the USA. So what are the positions that Professor has had? His biography can run into several pages. However, I'll be only highlighting his main events. In 2011, he was till date, he has been a clinical professor, Department of Medicine, Allergy and Immunology Services, University of Colorado. He has been a visiting professor and faculty at Department of Pulmonology, CMC Vellore, India. Hundreds of doctors from India and abroad have obtained their diploma in allergy and asthma under his tutelage. He has been a co-director of Diploma in Pediatric Allergy Asthma at Sri Gangaram Hospital, Delhi. He's the co-director of Allergy Asthma and the certification course, which has been introduced recently, of which I am also one of his first batch students and graduates, which is also popularly called as AASC, Allergy Asthma Specialist Course. He's the co-director of Pediatric Pulmonary Medicine, Bangalore. He's the co-director of Global Allergy Program from PGI Chandigarh. He's a consultant asthma and allergy specialist at Lakewood, Colorado, USA. So over to you, sir. I request Dr. Meera Ranjini to moderate this session. Thank you.
Namaste. Namaskara ellargu. Good morning to you all. Thank you for the kind introduction, Dr. Lakshmi. You didn't have to tell so much. We are very happy. Myself and Kamala are very happy and surprised to be here because I never knew this facility existed. And also I did not realize it looked so nice with the pool and everything. when I entered through those gates. So it has been a very pleasant surprise for us. And the third surprise was they even served a very delicious breakfast. So we are very happy, pleased, but at the same time a little bit drowsy because you gave us too good food. So today, I would like to, before even starting the talk, I want to thank Dr. Lakshmi for initiating this idea. Because we just had a very busy graduation yesterday. By the time I went to bed was midnight. And she had told me, you have to do this, sir, you have to do this. Then I had some more additional calls from Dr. Manjula. So I cannot refuse two ladies. I will be in big trouble. Especially Dr. Lakshmi, I know very well because her co-brother is my high school classmate. Immediately she will pick up the phone and complain what type of Vedanta I know. Like this. So I'm very pleased, Dr. Lakshmi, for inviting me here. And the topic initially that was given to me was a little bit, I actually suggested beyond skin testing and allergy. Then I thought about it, why should I go beyond? Let me start before that. Let me go ahead and start basics rather than talking about what we do later on. So change the topic to basically allergy potpourri. Potpourri is like chow chow, but this chow chow is a simple chow chow. It doesn't have a whole lot. So we are going to talk about some allergy diagnosis. And Dr. Lakshmi specifically told me, sir, you have to address anaphylaxis because that is a topic that all of us should know. Not just allergies, ENT, every physician should know, even lay public should know. I said, fine, we'll do that. So we are going to talk about those two topics. Then as I was sitting here, I thought maybe I should talk a little bit. I don't have the slides. What is allergy? Allergy, when I was in medical college, I used to use the word allergy for a very different purpose. I didn't like this anatomy lecturer. No, he was not only very mean, but he was also sort of not a great teacher. So I would say, allergy. So I would say I'm allergic to that person. Some of my classmates would also join. So allergy is something we could not handle. That is a type of thing. That is the level of knowledge, level of conversation that we had in the 60s when we were in, and 70s when we were in the medical college. Now, when we use the word allergy, it means totally different. Even for lay public as well as especially for health professionals, it is an immunological reaction. It's an immunology is involved. Why is such a change that has happened? So this disease actually is a very old disease, 2,500 years ago or more. The first pharaoh of Egypt was stung by a bee and he suddenly died right there. And those people 2,500 years ago were intelligent enough to observe something external caused the sad episode, something external. So they did not ascribe it to something internal, not heart attack or something outside has caused this problem. And that was the observation 2,500 years ago. And that observation was actually materialized only 52 years ago by the advent of the IgE that we are all very familiar today. This is what caused it. But IgE, where was it discovered? How was it discovered? Is something you should know. IgE was discovered at the same institute I did my fellowship. So there were two Japanese couple, Kimisha and Mario Terihoko or something like that. Ishizaka couple worked day and night. Very, very intense scientists. 2 rooms from where we used to be sitting as fellows, but before that, I had not done fellowship at that time. I know where they were sitting. Their pictures are there. And they discovered this substance that is causing this very adverse phenomenon. And they said IgE because E means erythema, the substance that produces redness and erythema. Why was it not discovered all these years? Is we did not have the technology to measure these items because it present in very small quantities in micrograms, 1,000th of a milligram. We all have it. Some people have it more. Some people have it direct against certain things. These are the people who are more to develop these adverse immunological reactions. And the same year, 1968, was also discovered in a patient who had developed a myeloma of those cells producing the IgE, those B cells, and was in Sweden, and Dr. Johannesson was responsible for discovering IgE in that patient, which was not that difficult. We had a myeloma, had tons of IgE in his system. And that patient became a multi-millionaire by selling his serum to all over the world. And this is the story of IgE. Since the discovery of IgE, on the same day the IgE was discovered, the scientists were thinking how to counteract this IgE. So this anti-IgE is not something new concept. It has been going on for 50 years and was being now materialized that we have antibody against the particular IgE called, we are all familiar with omalizumab and several other biologicals. Since the IgE was discovered, the marriage of allergy with immunology occurred. So for the first time, we come to know this reaction, an adverse reaction, is an immunological reaction. This adverse reaction occurs towards substances that most of us don't even pay attention to. They are very benign substances, mostly harmless to most of us. Who is going to worry about some dust on the floor? Who is worried about that cockroach? Who is worried about some of those pollens? People don't even pay attention to it. But people who are producing IgE antibodies against those substances are highly aware of it because they get acute symptoms, chronic symptoms. They have diseases that we have different terminologies and different names based upon the target organ, allergic rhinitis, allergic asthma, urticaria, food allergy, drug allergy, all these things we have depending on the target organ. So what I would like you to appreciate, disease is old, explanation is new, disease is very common. Why is it common? This is a disease which is typical of this common concept that we use to describe many other diseases now, is what we have is called environmental genetic interaction. Environment genetic interaction. The environment is there. We are the genetic thing. But we already have genes already being transmitted to us. How is it somebody else, my neighbor, my friend does not react, but I do? Why do I react? So if I take a little skin test you right here, 40, 50 of you, about 10 of you will react, 30 of you won't even react. Why is this? But the reason for that, 10 of you are genetically prone. Same environment we are all exposed, but you are genetically prone. Why I am saying genetically prone is your epithelial integrity is compromised. You have a leaky epithelium. Your cement of these cells between the cells of the epithelium is weak, like flagellin, ceramides, we call it. You know, a lot of dermatologists know more about all that. So it is similar to, if you look at the floor, you see these tiles, and these tiles are perfect, very smooth. It's a little raised, you know, right away. What is it holding it so smooth? It is not the tile, it is the in between the tiles is the grit. The grit is what is holding it, and the grit is weak in the epithelium. So there's a grit. So that grit, what we call as adherence junction, tight junctions, you know, you can read about this. And this grit is genetically weak. So once it is weak, the environmental agents will enter through those leaks, through the skin, through the mucous membrane of the skin, of your body, of the GI tract, respiratory tract. So our body interacts with the environment in three major systems. One, skin, which we all know is the largest organ, GI tract, which is from mouth to the rectum, and the respiratory tract all the way from the nose to the alveoli. We are totally exposed to the environment, not your heart, not your brain, not your liver. So these exposed organ systems directly are in contact with the environment. So, and they are lined with epithelium. You know that because of the anatomy, physiology you learned in second MBBS. And when that grit is leaked there, these extraneous substances enter into your system, and you are genetically prone to develop IgE antibodies called, that is why they call it Th2, you know, your lymphocytes. And these substances, the dust mite, a cockroach, a pollens, have got what they call as proteases. Proteases, what they do is, in addition to the epithelium being leaky, it actually causes some inflammation, makes it leakier, more leaky. So you have a leaky mucous membrane, and more substances get in, and your body will react. Once it reacts, you have what we call as inflammation. Enama? Haga. Next year I will sit. Okay. Okay. Thank you. Whenever I feel like it. I had polio as a child. So in the last 3 years, I have had some post-polio syndrome. So my weakness has increased. So I was not limping that much. I used to limp a little bit. And I would boast to people, you know, I have climbed Tamandi Hills every day for 20 years. And I have climbed this Mount Kailas, this. But now I can't climb here properly. So I don't want, you know, like these things happen. Anyway, coming back. So this leaky epithelium is what causes it. And one word about genetics. I'm not a geneticist. Genetics, we come with a set of like a fingerprints. We come to this world into this genetic pattern. We all have different genes. And you must have heard about epigenetic changes. These genes are not static. They are also capable of changing their configuration. So the configuration of these genes can change based upon the environment. It doesn't have to be dust, molds, and all that. It could be the temperature. It is not only environment outside, environment inside, and even they have found psychological environment. If you are upset, it will change your genetic pattern. So that is why people who are under having a lot of stress get autoimmune diseases and all that, because they are also genetically transmitted. So it can be influenced. And the other disturbing thing is epigenetic changes can be transferred to your future generations by 2 generations. So that is why we say have good lifestyle, so that not only you will get healthier, your offsprings also will have a healthy life. Otherwise, you are going to transmit it. So the type of life we lead is not just limited to us. We are going to transmit our defects to our children. So that is the message you need to know about epigenetics. Allergies is one of them. So you see now that our generation did not have much allergy to speak of. But if I were like 30 today and I'm developing epigenetic changes, my child will develop allergy. And that is why in the 2nd generation or even a 3rd generation, the allergy diseases now are in epidemic proportions. There was an article I read several years ago where about 50 or 60 years ago, somebody wanted to do research with allergy. He waited something like 6 years to get 9 good cases of allergic rhinitis. I want to search. Now I wait about 2, maybe 30 seconds to find that number. If I wait for 2 hours, I'll get 50. So it is such a common problem. Now that will give you an idea of what we are going to talk about. Okay. Oh, Martin. So okay, we are going to talk about allergy diagnosis. I know you are all experienced physicians here, but I thought I should mention a little bit about allergy history taking, because it is different. You know, I met very good dermatologist, Dr. Lakshmi Sasmet. As soon as I saw the dermatologist, I felt like complaining already, sir, look at this rash or something. Because I know dermatologists, what they do is look at the rash, make the diagnosis, and then they speak. He already knows the diagnosis. He wants to confirm it. Allergist is totally separate. When the patient comes to you, he looks good. He is not looking that sick. So you have to find out what is the bad about him, what is going on. So you have to spend a lot of time. And he has been already brainwashed by so many people that this is good, this is bad, this is what to do. So there are people who have got a lot of misinformation when they come to you. So allergist spends a lot of history taking, he spends a lot of time, 20, 30 minutes like that. So we need to talk about how to take an allergy history a little bit. And there is a thing called second history. We need to know what it is. And at Dr. Lakshmi's request, I also added a little bit about anaphylaxis. Now, let me ask our alumnus here, what are the ways you make diagnosis of allergy? Answer 1, answer 2, answer 3, Dr. Ranjani. I remember your name because my daughter is also Ranjani. Mira. History taking. Second would be your skill test. And but like you said, the second history as to what would be the cause from the history that you're correct. That is the history. Same. Thank you. Answer is history, history, history. Okay. So the answer to your diagnose, how do you diagnose allergy? History. Then second one, are you sure? You can say loudly history. Another third one, I won't say, but you have to shout. So history is the most important way of diagnosing allergy. Why is it so? Now, few basics, I don't have to go through this slide because I just added on there to bring out a few points. Just to make sure we take a good history, we have to observe certain basic disciplines. That is, you have to have an eye-to-eye contact with the patient. You have to concentrate on the patient because patient is looking at you like a hawk. Okay, he wants to know whether you are paying attention to him, so or her. And do not use the cell phone. Do not take messages. Keep the cell phone away. Don't do this and say, oh, okay, I'm a light. Oh, okay, like that. Don't do that because he will get annoyed within 2 seconds. So take a very good history, pay a lot of attention, and let the patient speak because they did a study, published study where they found how many times would we interrupt the patient when you're taking the history. What do you think? How many times? 8 to 15 times. 8 to 15 times we interrupt the patient. Then I thought something will go, and then it is not leading me active. So that thought, say like somebody, when you are talking, somebody interrupts you, thought process is stopped. And you don't know, you are confused. And also when the patient comes to you, patient is very nervous. He is afraid of the doctor. You know, a lot of the public, you need to know that they think you are some devata or something, and you are something superhuman. I don't know how to talk in front of him, and they are nervous. Okay, most of them. Nowadays, things are changing. Now they are angry. Okay, so before, when my father used to take history, you know, he was a physician, everybody would have a lot of respect and all that. Now it is it's changing. So anyway, so a lot of attention has to be paid, and patient wants to be heard. That is the message. You can always lead the direction. How do you take the history? As I just told you, and one thing is, an allergic patient is an anxious patient. He's worried, he is unsure, he's misinformed. He has already seen so many doctors, including alternate physicians, you know, and as I was telling yesterday, this was a very similar type of talk yesterday at the AASC graduation. So when a conversation happens in a bus or train, I have listened myself sitting as a passenger. What do people talk about? They talk about some food. They talk about, ladies talk about sari, jewelry. And it is also not uncommon. They talk about doctors. Very, very common topic. They will keep on talking. And so this conversation about us happens at all levels. So if you do a good job, people talk good about you. And that is why the best referrals comes from patient referrals, not from your colleagues. So we need to make sure that when the patient comes, our main job is education, because they are misinformed, they are confused, they are angry, they are anxious, they are worried, not only about the disease, but also about the fees, how much you'll have to pay. All these worries are there. So you need to put them to more comfort and educate the patient. And especially allergic patient take a lot of time. And if you look at the average time that the doctor spends with any of his patients, it only varies between 2 to 5 minutes. Okay, average. There are people who spend a lot more, but average is 2 to. How many patients did you see? Oh, I just saw about 80 patients. How can you see 80 patients? You should be at the end of the day a patient yourself. Like it's like a camp. But that is not uncommon, because I'm not blaming anybody, because the load is so much. Low people want to see you. They will wait. If you make them wait, they will be upset. But as a subspecialist, as a specialist, you can't do that. Justice to yourself or to the patient. You have to spend time, and they will understand, because these patients who will come to see you have already had the problem for 10 years, 15 years, and they don't mind waiting for 2 weeks or 1 month to see you, but they don't want you to hurry up and take a haphazard type of history. So, and as I told you, this patient who comes to you for allergies, he's always looking for answers, and that is big problem, because you may not have answers for all his problems. You need to let him know that, tell him truth. Tell him that you got all these problems, but I may not have all explanations. Plus, I may also tell you that all your problem may not be allergy. So I will tell you what is allergic, what is not. I can tell you that. But whether I can cure you is a different matter. Okay, it is not like a strep throat or some infection. I give you antibiotic, you get better. This disease is different. I may not be able to cure you, but I may make your lifestyle better. I may make your quality of life better, but I won't use that word cure. So do not get confused with cure and quality of life improvement. So these things can be told straight away, so that they know what are the limitations of coming to see you, and they are already prepared psychologically. And you need to also know, like you are all senior physician, you don't have to be literate to understand all your instructions, because even including a villager is extremely bright. He has more smartness and more wisdom than some of the city people, because he has seen life and he's tough and he knows. So we need to just tell him the truth, and this is what I can offer you. This is what I cannot offer you. Okay, you tell him right there, so that expectations becomes less, and because he thinks everything is allergy. Say, for example, a city person from Bangalore, he wants to first examine you first rather than you examining him. He will have already gone through this Google business and figured out all these different diseases and understands half pathophysiology will have learned all. And he will start examining you. Sir, what do you think about the use of anti-leukotrienes? What are you anti-leukotrienes? He says inflammation. IG, sir. High, sir. My IG is high. So I have allergy already. That he will test you. Then you have to, so this is a different ball game there. Cheating. Villager will come from Somanahalli and say, sir, you give me a shot, get me better. I want to go and mow this one, till my land. I have to take care of the sheep and cattle. I want to feed my family. So get me better next week. I don't want to go through all this too much of talking. I just want relief. So there are these are the types of scenarios we all face, and you have to deal with this. And I want to let you know, patients are same across the globe. Same type of problem, same type of thinking, same type of expectation, same type of quackery, same type of thing will exist everywhere, including America. We have a parallel quackery system. It is nothing like there is no quackery there. Yes, there is incredible quackery in America. So this guy has already seen a lot of doctors. He will have tried a lot of medications already. You see, there is where the difference comes. In India, you can go to any pharmacy and say, this is my problem. What do you give? Pharmacy, Dolo. You take the Dolo. And he will give you. This I didn't know until today. We are good customers for you. Our family take Dolo, especially her cousins. You all know, especially after this pandemic, Dolo consumption is high. So then this patient, allergic patient, will talk to the neighbor. He says, I also use this spray. You also use this spray. You'll use the same spray. Push, push. I don't have to spend extra money. And somebody will give him the pills. He will consume it and gets better. Oh, you are the doctor. You're very good, very good. Whom didn't you go? I went to that doctor. You also go there. And so he will go there. And that is how the Indian system works. And you spend all the time. And this allergic history, as I don't have to spend much time there, it's a very prolonged history. The reason for that is, like any other medical issue, you spend time to take the history, because as you're taking the history, you need to know it's not a mechanical thing. History is never a mechanical thing. If young doctors here, you should understand, never treat history as a mechanical thing. That means the printed sheet is given to you. You are asking questions one by one, very mechanical. That's what a clerk does. That is what your assistant does. Not a physician should never do it. Physician, when you ask a question, you should know why you are asking the question. You should know the patho. Why am I asking that question? Somebody says, I can't breathe. You can't breathe through the nose. So that means either there is swelled up or there's some deformity, and I can't breathe through one side. Then after some time, I can breathe through the other side. You already know it's a nasal cycle. But I can't breathe at all on one side, some sort of a deviated septum or tissue. So all these things should be, I get this clear nasal discharge. I get this swelling more at night. All these things patient is telling you. As he is telling you, your thinking process, oh yeah, this patient has this patient has that. So your thinking process, you are doing double job. You're listening and thinking, analyzing. It's called analysis. Should be done automatically. For any disease, cardiology, rheumatoid, anything, we have to do this double business, listening and analyzing, because if you don't do that, at the end of the talk, you are thinking like this, patient will lose confidence. Or let me look at my book, what happened with you. Then he will walk out. Okay, so you need to have that analysis automatically happening at the end of the conversation. Okay, why don't you have a seat? And I know, but at the seat, he's sitting you in, that means he's giving you time for more analysis. Okay, if you want more time for analysis, put a thermometer in his mouth and he has to shut his mouth. Don't take it out for 3 minutes. And that will give you more time. And he's happy, very good temperature is being taken. So when you do these things, what is happening? Irbeku. Thank you. You are developing this stuff is very general. So as you are doing this type of interview, what is happening is a relationship is developing. Patient will remember this interview for the rest of his life, because he will say, that doctor spent 20-30 minutes with me. He asked me what happened to my father. He asked me what happened to grandfather. He asked me what type of bed I am sleeping, whom I am sleeping, what type of pillow I have, what type of. He asked me what type of pillow, what did I eat, what I did not eat, what happened when I ate. This type of detail is asking, and he's asking me about weather, this. So what I am doing is I am evaluating this environment, both internal, external, intrinsic, extrinsic. I want to know what is all happening around him. Oh, sorry. So this is the reason why allergic history is a very special type of history, where you evaluate the whole patient, because physical exam is of limited use. At the end of that history, you already know this is an individual having these complaints, which may not be allergy, but tend towards allergy, maybe. Because when you're taking these symptoms, say for example, patient says, I am sneezing a lot, but I am also itching a lot. So itching is telling you there is histamine release. Sneezing means there's a mechanical factor, something external, little mucus or something like that. So not all sneezing is consistent with allergy, but itching is more indicative of a histamine release, which means there's a mast cell activity. Mast cells and basophils are active. So that is the thinking process. Okay. So if somebody says I'm stuffy, I'm having running nose, I sneeze, doesn't mean much of an allergy, but sneezing will add on. There will be some seasonal variation. There will be some diurnal variation, because allergy is a diurnal disease, chronobiologically very active. Okay. So you need to be aware of these things. And like that, if somebody tells you I got itchy eyes, itchy nose, it is very, very suggestive already. Okay. Somebody says I'm only stuffy, it indicates inflammation or some anatomical problem. If I have some running nose, that means there is mucosal congestion. It could be so many other reasons. And people will say, I go into this shopping center more or something, I start sneezing in that aisle. And yesterday, the vice chancellor, my classmate, he was retired vice chancellor, Dr. Chandrasekhara, gave his history as his main chief guest speech. He said, I go in the morning for a walk at 4 o'clock, I sneezed a lot. At 6, then somebody told it is 4 o'clock problem, you go later. He started walking at 6 o'clock and sneezed less and sneezed very little at 7:30. And he thought, somebody said it was pollens. I thought pollens, because there is a lot more aeroallergens during early morning hours. I talked to Dr. Abraham later. He told me it is not pollens, it is mold spores. A lot of mold spores because of the moisture and all that is there. But anyway, aeroallergen content is very high early morning hours. That is why you could have more manifestations. So there is circadian rhythm. And also another thing, what happens, your own body allergic inflammation is worse at early morning hours. So there is a lot of allergic inflammation at 4 o'clock. And have you heard of chronobiology clock? Chronobiology clock, chronotherapy, chronomedicine is a very important part. So chronobiology clock tells us at what hour of the day or night our physiology, body physiology or body pathology, pathological mechanisms are at peak. It is called acrophase. Okay. In our medical school, when I was in medical school, we were all taught that internal, external environment are constant and equilibrium. That is what we were taught. That is not true. It is never in equilibrium, or it is not constant. It is moving every hour, it changes, keeps on changing. Because say, for example, simple things like pulmonary functions, they are the best at 4 p.m. That is the time they come and see you in your office. And they are the worst at 4 a.m. They never come and see you at that time. So it is a nocturnal problem. Same thing like diseases. There are several diseases, cardiac problems. You know, myocardial infarction is an inflammatory disease and it occurs in the early morning hours. So he will have a pretty decent when he comes and see you, but the disease occurs at some other time. Most of the deliveries, babies are born between midnight and 4, something like that. So it's a lot of circadian issues. Now, few things is about, now history has given you some information, then you do skin testing. Why do you want to do skin testing? Skin testing is done to find out what specific IgE antibody time is. For 10 minutes, 15 minutes. I don't know what time it is, but you give me one hand like that. So IgE antibodies specifically are directed at certain things. And so skin testing is an indirect method. Indirect method. Why do I say indirect method? Reaction is occurring in your nose, reaction in your eyes or GI tract, but I am using the skin because it's convenient. I'm using the skin because the same mast cells are also there. I'm also using the skin. These mast cells also have these receptors for these IgE antibodies on which this IgE antibody goes and sticks on. It is called homocytotrophic antibody. And the IgE half-life is only 2.5 days, but once it gets stuck to the mast cell, its life pattern changes and it is good for almost, it get extended for 3 to 4 weeks. So it is there. So you do the skin test. So when you do the skin test, what you're doing is just make a little hole in the skin, expose that antigen to go into your dermis, and the mast cell, which if it has got IgE antibody on the surface, if it has specific IgE antibody, it will grab the antigen and you get the reaction. You have to have 2 identical IgE antibodies sitting side by side to grab the antigen. the important word I said is identical. I'm looking at your dresses here, and how many people are having same two blue sarees side by side? How many people have two black dresses side by side? Nobody has. Everybody has different dresses. That means none of you are having identical. Say like you are only 50, but if you are 1,000, chances of a red shirt sitting by the side of red shirt is pretty good. Same thing if you have a lot of IgE antibodies, two identical antibodies sitting side by side is much higher. So having a positive reaction, that means two IgE antibodies grabbing the antigen, chances are you have a lot of IgE molecules sitting on the mast cell. There is histamine release. And if the histamine is released, it causes the triple response, vasodilatation and exudation and erythema. And you get this wheal and erythema. And that is what a positive reaction. And that indicates that you have a specific IgE antibody against that particular antigen. And that is called sensitization. So if you are sensitized, does it mean you're allergic? Yes, Dr. Rajani says no. She's right. If you are sensitized, that means you are producing IgE antibodies, but you may not have symptoms. That is why I said 10 of you may have skin testing, only 2 of you may have symptoms, which means 10 of you have produced specific IgE antibodies, but you don't have symptoms, which means you are sensitized, but you are not allergic. Allergy is a clinical term. If somebody says allergy, that means you're having symptoms. If somebody says I'm sensitized, that means you're positive skin test. So we now know that if you are allergic, you have to be sensitized. If you are sensitized, you don't have to be allergic. There are a few exceptions where you can get allergic without sensitization, like latex sensitivity, drug allergy, there are insect allergy, those 3 conditions, you don't need sensitization. So why? I don't know. So after this, what I have told you, we now know skin testing is giving you many lot of information. It has given you the pathophysiology. It has given you progression, possible mechanism. And because of that, it can also give you whether this patient will respond to treatment, whether he is going to be a failure of the treatment. So is there a scope for further treatment? All these things you already know before you touch the patient. That is the beauty about history. And the other things I've already told you. And how do you make, now there is a word called progression. How do I know the disease is progressing? The progression is a word that we use a lot in allergy. That means allergy disease is not a static disease. Every day it changes, every few months it moves forward. They use the word allergic march. It's a little bit controversial, but allergy is a condition that keeps on changing. And how do you make out, is there a test for it? Yes, there is a test, but it is a clinical expertise that makes you diagnose progression. And those are subtle. If your patient says, you give this inhaler, you give this these nasal inhaler, antihistamines, after 2 months, you will say, how are you doing? Patient says, I am better, but if I miss this medicine, I have symptoms. Or they will say, my son is better, but when he runs, he coughs. He's better overall, but he coughs at night. It doesn't bother me, doctor. I'm okay. I'm happy. Compared to before, is a lot better, but I have seen this. So she is happy. Patient is happy. You are not happy. You should not be happy. It's because what you have found is the response to the medication, response to the treatment has gradually become less and less, which means the same dosage is being given, same compliance is there, but slightly more and more symptoms are occurring, which means it is a clinical progression, very subtle, very subtle. So that is why we tell the patients to maintain a symptom diary, medication diary. And that is the reason why you have this ACT, asthma control test, to find out what happens in 3 months, not on that day when they come and see you, not on the night before they come and see you. When you do spirometry, everything looks good, doesn't mean anything. That's why I told, keep on doing spirometry too often, because it's not telling you much. Spirometry has to be used for diagnosis and maybe follow up once in 6 months or a year. but not for regular control. ACT is more useful, or peak flows maybe. Now you do the skin test. Initially, say like 6 months ago, you did a skin test and you want to repeat a little skin test. You can repeat those few ones, you can repeat on the children, maybe 5 or 6. And if the size has increased, it is immunological progression. If the symptoms have increased, that is clinical progression. So if you have both clinical progression, you have immunological progression, you have evidence to say your disease is progressing. I am worried. So I want to do something about it. And the only thing I can do is allergen immunotherapy. And that is the only modality that will help you, because the cell that is driving this whole thing is not response. It is not even touched by corticosteroids, not touched by antihistamines, not touched by montelukast or anything, because it is a T lymphocytes that driving it. It is not tissues. It is a lymphocyte sitting in your lymph nodes that is driving this whole thing. So there's only one modality which will touch the T lymphocyte, is allergen immunotherapy. So that is why allergen immunotherapy is a powerful armamentarium you have. And that is how the oncologists now use the allergen immunotherapy, because they also target T cells. Okay. And it's very, very powerful if you use it properly, and it's very highly effective. And that is one modality. If you use it right, it can reverse the disease. It can stop the march. It can actually, we use the word, I might be able to cure you. I would never use the word cure before. Here now with some confidence, I can say, maybe I will be able to cure you because you have come at early enough, I can do it. Another thing allergy immunotherapy does is it prevents neosensitization, that is development of new sensitization 50% of the time. So say like I take a group of 20 children, I do the initial testing. Here I do the same testing on them. Their skin test reactivity, they will have developed new sensitivities to several antigens. In almost like 80 to 100% of the time they will develop. Whereas I put them on immunotherapy and do it, there is a 50% reduction in neosensitization. So it works in many different ways. So progression is something you should be very much aware. Second history is where you put all these things together and summary conference. I'm going to go fast now. That means you are going to do correlation between history and all these different findings. So that is expedition in Ladakh. Okay. Now switching gears, anaphylaxis. Can we go anaphylaxis? Okay. Anaphylaxis is an acute allergic reaction which is terribly rapid in onset, and it can be potentially be fatal. But how many people really die of anaphylaxis? Only 2%. 98% recover. How is it they are recovering? You have an endogenous production of epinephrine. Your body takes care of yourself. Otherwise, a lot of us will just die, because many of these people who have had anaphylaxis get better on their own, but we make sure they get better much faster. We can't take it chances. Now, anaphylaxis, how often, how frequent is it? I don't know. We don't have a very good statistics here, but we know it exists. It is increasing. Around the world, it is increasing because of several different factors. And in India, we don't have a good registry for anaphylaxis because it's not a reportable condition. It's a clinical diagnosis. Since there is no test for anaphylaxis, people label anaphylaxis as by different names. They may say heart attack. They may say some sudden death. Somebody says it will stroke. Somebody says he hit his head. All these things. Somebody finds somebody dead on the street. Oh, he died of some heart attack. But actually, it could be anaphylaxis. They still suspect. I don't know. Somebody told me this very, very famous actor, Puneet, they suspect he may have what they call as a exercise food-induced anaphylaxis, because he took some food and then did this intense physical activity. There is a condition called exercise food-induced anaphylaxis, where with eating food and then doing physical activity releases massive amounts of histamine in these people and causes cardiac arrest, and they die. Okay, hypertension. And I'm not saying he did it, but there's something you need to be aware of. And what could have proven it? After he died, you can still take some blood 2 to 6 hours after and measure the tryptase. And if it is really high, that is something suspicious. But if you had a baseline one before and then do it later, you could. But there is no lab test for anaphylaxis. There is supportive evidence of anaphylaxis. So it is a clinical diagnosis. What is the most common manifestation that you suspect somebody is going into anaphylaxis is dermal. If you have a patient who is given some offending food, or you give an allergy injection, or you give an offending medication, if the patient says, I don't feel that good, I feel hot, that is all he will say. I feel hot. That is an indication of histamine release. There is some reaction happening, and you can't say, oh, bhala shake, this is because of the temperature, I'll put some fan and all that type of, that won't work. Okay, because sometimes it will give you some time, sometimes there is no time. It just zooms like that, because histamine is a very fast acting mediator. It will drop the blood pressure down. He will go into hypotension. So even if you suspect, that index of suspicion should be high. Even if you suspect anaphylaxis or something happening, give epinephrine. No evil business, no corticosteroids, nothing will work. So epinephrine is fast acting. It may be unnecessary, but it is life-saving. It will reverse the activity and give him the protection, both alpha, beta, it works. But there are some people who do not react to, who will not get better than anaphylaxis. I'll show you that slide. But epinephrine is a lifesaver. Epinephrine, the faster you give, the earlier you give, the more you give, more number of people you can save. The longer you delay it, delay in the delay as well as not giving it, and not giving it properly will cause major issues. Now, is there a contraindication for the use of epinephrine? Answer is big no. There is no contraindication, but it can cause other problems. It can increase the heart rate. People who are having some angina issues may have something. But if you hold back epinephrine because he has got these issues, it is almost malpractice. Okay, never hold back epinephrine. Don't give this evil call in business. So I'll tell you why such things are important, because even in major institutions like Christian Medical College, it occurs. Because when we were doing our own program, one of our own students, he was staying in a little cheaper hotel, because expensive hotels near that area, he was cheaping, and there were bed bugs. Okay, I forget that particular generic name. Bed bugs can cause anaphylaxis. So he has been stung before during PCS1, he's already sensitized, comes for PCS2 and gets stung and goes into almost like a state of shock. Brought to the emergency room at CMC Vellore, given Evil and Efcorlin. And he gets better on his own. That's what I told you, 98% recover, because they produce their own epinephrine. They have their own defense system. So Evil and epinephrine didn't work. And once, such things are happening across the country, everywhere. So if you start looking at all these emergency rooms in different corporate hospitals, they can easily give you the data. That is one study that can be very easily done. You have to approach Apollo or one of these Fortis hospitals. Give me all the patients who come with these type of symptoms to your emergency room, and what are you doing, and what is the follow-up? That is all, 5 questions, and you can get a fairly good idea, and it will be a very, very nice paper. And we actually did a little survey of our own allergy doctors from our program for food allergy. And actually that was a very small abstract, actually done by an American student from NYU. And he took the lead, and several of our doctors are also involved. He presented at Singapore. And what I found was 2 things that came out there. Anaphylaxis does occur quite often. And there is a huge delay in administering epinephrine in India, and there is a lack of usage. Only 40% of the anaphylaxis got these adrenaline shots. This is the latest data based upon that abstract that I can tell you. So there is 60 to 70% chance epinephrine is not used in these occasions. So that raise has to happen. You don't need that portable epinephrine or all that luxury thing. Any epinephrine will help. There are some issues, but it will help. So that is the big message. And do not wait for, he's feeling hard. Okay, let me see what happens. Don't do that. No waiting. Let me see whether the blood pressure will go down. By the time you take the blood pressure, it may not be recordable. Okay. So it won't give you enough time. Okay. So what it means is high index of suspicion. In children, foods are the most common reasons why it happens. Again, going back to history, you will find it. And best thing is treat and then take the history if you suspect. Don't keep on taking the history and the patient is going into hypertension. Treat, no problem. And sometimes it is easy to miss the first episode, especially if you don't have a proper history, you don't know, but having a high index of suspicion, you will be able to catch it. In children, very difficult to diagnose anaphylaxis. Children will never complain. They won't say, I'm feeling woozy. Adult will complain right away. I don't feel good. I am itchy. I'm this one, that one. Children are not like that. You have to watch, and many times there are not facilities to take blood pressure in children. You don't have the right cuff to take the blood pressure reading. So that is another problem. And don't wait. Okay, I'm going to take, my professor told me take tryptase. So let me take tryptase and then treat him. Don't do all that. This is never do that. Go treat him, let him get better. Tryptase will wait. There is no lab test for anaphylaxis. Even if you don't do tryptase, it doesn't matter because the tryptase sensitivity is only 72%, specificity is 98%. Okay, so there's a 26% chance that you will miss having an elevated tryptase even in the presence of anaphylaxis. So it is not a thing which is universal. It is the high, when you are talking about tryptase, you need to know what is the range, how between pre and post, what was the increase, 30% increase. By the time you find out all that, it takes like 2 weeks. So it is something you could do it, but if you don't do it, don't worry about it. And you should know what is this beta tryptase, what is this alpha tryptase. People don't talk about alpha tryptase. Alpha tryptase, if it is high, it only tells you that how much of mast cell you have, what is the mast cell load you have. So there are certain diseases like systemic mastocytosis, cutaneous mastocytosis, mast cell activation syndrome, where you have a lot of mast cells, and your baseline tryptase is high. And the reason for that is important is if you have a baseline tryptase is high, which tells you if the alpha tryptase is high, that means you have a lot of mast cells. You are at a higher risk still. You will produce a lot of beta tryptase too, especially with insect stings, reactions. So you are more prone to have anaphylaxis with insect stings. The first shot itself you can have. So that is where it is important. And beta tryptase doesn't go up with food allergies reactions. So tryptase has good, but has limitations. So when somebody has an allergy, had this anaphylaxis, go ahead and treat. If you're not an allergist, go ahead and refer them to allergy specialists. Very, very important for somebody to spend some time, take the history, figure out what it is so that it won't get repeated. They also get emergency treatment to be taken and education. So epinephrine is a lifesaver, not IVL, not solicotive, not IV fluids. Quickness of response is very important. High index of suspicions. You can repeat epinephrine. It has a narrow therapeutic index. It only works for 10 minutes or something. You can repeat it 10, 15 minutes, 3 times. And it is truly a lifesaver. Now, at times it doesn't work. So why it doesn't work? It's a lifesaver, it's not working because there are some people anaphylaxis so severely, like such a massive release, there is a chance, 10% chance epinephrine will not work because there's a rapid, massive histamine release. They die in spite of giving epinephrine. Now, some people do not know how to use the epinephrine, and they will just take it, and they will give it subcutaneous. So subcutaneous will not work. IM has to be given. They give it in the arm. That won't work. You have to give it in the lateral thigh or in the thigh muscles. They have found that is the best way it is absorbed. Or if the patient is very, very fat, it will still be subcutaneous. You may think it's intramuscular, but if you have a big fat patient, which is not uncommon now, is use a 1-inch needle. Go deep and give it. Nothing will happen. He will say, he may not say anything because, so just give it. And expiry date. Don't worry too much about expiry date. If it says January of 2022, it expired, sir, don't give it, sir. I said, don't worry now. I know how much it's active because now it is July. 5 months down the road, it will work from 100 to 95%, it will work. So it is inversely proportional to the number of months after the expiry date. Okay. And the other thing is position of the patient. Never administer epinephrine on a patient. People can still come to you standing with anaphylaxis. So never, okay, sit down and then give it when he's standing. Never do that. Have him supine position. Very important. Leg elevated is perfect. Put him down. First line now, leg elevated. But nothing, so even sitting is a risk. And beta blockers, ACE inhibitors, there is a lot of evidence in asthma, but not in anaphylaxis. Don't worry about that in anaphylaxis. And metabisulfite is another product that can cause it by itself an acute reaction, mechanism unknown, but it is a ingredient of the epinephrine itself as a preservative. Okay, they still need to be researched. And this is the exact composition of the epinephrine I have put in there. And you need to know that sometimes the labeling doesn't match what the content is. So there may be a less epinephrine or more epinephrine in the same preparation, which occurs very less. In the US, it happens because of the strictness of the USDA, but in other countries, there's a possibility that what the label says may not be what exactly it is. So you can probably double dose it, no problem. If it doesn't. This is telling you just a summary. I won't worry about it. No contraindication. This is telling you made in Krishnamurtipuram epinephrine, or Jayanagar epinephrine, where you can make your own mom and pop operation, but it is still good. You just have to take a spectacle box, put some preloaded syringes, put some syringe. Because I had a patient from Calcutta who was having recurrent anaphylaxis, idiopathic, and he took a train to Calcutta, 40, I don't know, whatever. He had 3 episodes. Okay, and he had given him enough epinephrine. Every time he self-administered, in his thigh. Don't do this business. Have them do it. It's much easier. And he reached Calcutta alive. And then he gone and seen the specialist I had given the name. So it works perfectly, and that is from Balachandra. He uses a much better type of very flashy thing made in Bangalore. I don't know where it is, but it's very flashy. And same thing, it's covered. So the important thing for epinephrine is to be covered, should be kept in a dark place. The temperature 30 degrees, doesn't have to be refrigerated. And if it is discolored, that means it is oxidized. It may not be that good. And they have done studies in US where they looked at a 4-year-old expiry thing, 4 years of expiry, and still it worked. So it doesn't mean you have to always use expiry one, but don't look for, expired, that's what I want. Don't do that. But if you, if you have one, patient is anaphylaxing, don't stop and say, I'm expired, I don't want to use it. Use it. That is the message. And these are 2 articles you could look up, the parameters, practice parameters, and also what we call as an emergency drill. This is the last slide. So the emergency drill is fire drill, in the hospital they do it, and make sure everybody knows where to run and what to close, which door to come out and all that. Same thing you need to do in your office. You have to fake an allergic reaction. Okay, tell your assistant. Otherwise, when the real thing is happening, you'll say, where is that? Where is this one? Where is this one? He will start searching around the office, and he will find some other ampoules. So all this confusion happens. At that time, you are so this one out. You don't know what you're seeing, what you're doing, what you're seeing. So it should be drill has to be made. Your drill should also include documentation. Documentation is very, very important in anaphylaxis treatment. It's not treatment. As you are giving it, you have to loudly say, I gave epinephrine 923. I gave one more 942. I did this, I did that. Somebody should write down, because medico-legally it's very important. And don't alter that thing, 922, I'll make it 928. Okay, there should not be any alternation of records. Perfectly recorded, because a lot of the anaphylaxis cases will end up in courts. 5 years later, they say, my child was born with a head looking like that. That is because of the shot you gave. When I had anaphylaxis, you did that. Because pediatricians can be sued for 20 years. You know that? 18 to 20 years later, he said, my eyes was looking like that because you did this sound. So you have to be very, very careful. So I will stop here. Thank you very much for giving the chance. Thank you.
Thanks a lot, Professor Vedantan sir, for a wonderful and illustrious lecture. However, any amount of time is insufficient for discussion with you, because we will extend that question and answer session over lunch. Whoever has any doubts on any issue or aspect of allergy can approach him. Okay. Now we will move on to the lighting of the lamp ceremony. Sorry for the interruption of the events. So I request Professor Vedantan sir, Dr. Deepak Haldipur, Dr. Vishwas Vijaydev, Dr. Manjula for lighting of the lamp ceremony, please. Madam, ನೀವು ಯಾವ್ದಾದ್ರು ದೀಪದ ಬಗ್ಗೆ ಹಾಡು ಹೇಳ್ತೀರಾ?
I think Vishwas was there that day. This was about 3 weeks back, a patient with Crohn's disease. I was planning to do a microlaryngeal excision, and she was also a known asthmatic. So my anesthetist before induction gave an ampule of hydrocortisone, and patient developed a severe anaphylaxis to hydrocortisone, arrested, and then 3 DC shocks, the heart did not start. The 4th one, luckily it started. Then the BP was 24/34. And then after, I think about 3 to 6 minutes, I think the BP also came up. Her heart had stopped for 8 minutes, if I'm correct. Touch wood, she recovered fully. So this Dr. Vedanthan's talk is so important. Luckily, we happened to be in the operation theater, number 1. We had 3 anesthetists because 5 OTs were going on who could help in revival. And after the 3rd DC shock, I told the anesthetist, why don't you try the 4th one? 4th one worked. We didn't give up. And luckily for us, she's a chronic asthmatic, so she was used to chronic hypoxia. So her brain withstood this assault. And this happened in the OR. So what Vedanthan says, please have a mock drill. See, there's always something called as an exchange value. I always say this. You're a neurosurgeon, you're operating on a brain tumor, you have an anaphylaxis or a problem. Patient dies, the relatives will take it. You're an oncosurgeon, they will take it. You bring them for an adenoid or a tonsil or a microlaryngeal excision of a cyst, or God forbid, a simple allergy test to treat allergy, and you lose the patient. I don't think anybody will take it lightly. Fortunately, the guns are not available in India yet. So to that extent, we are saved. But today's lecture of Dr. Vedanthan, and never hesitate to use this epinephrine. It's a wonderful drug. Somehow people have this problem of using it. And then, they go slow, give it subcut. I think today hit the nail on the head. I think this is very important. This is my experience. I mean, after 32 years of surgical practice, I didn't know that people could be allergic to hydrocortisone. I went to the Google after 5 minutes to find there are many who are allergic to hydrocortisone or the preservative which comes along with it or whatever. God knows what it is. And don't look for, as he correctly said, date of expiry. Whatever drug you have at that time, use that. This has been my experience. If it is of use to you, anybody who arrests also, don't give up. Your cardiac massage going on for 10 minutes, 12 minutes, because we were very worried, with 7 to 8 minutes of cardiac arrest and low BP for 14 minutes. We thought this lady would be a vegetable. We thought there will be so many problems of chronic hypoxia. Nothing. After 6 days, she walked out totally without any problem. So it only means that you need to manage it well. You have to learn these drills well. Don't wait for complications to happen. Be prepared. Yeah. Number 2, Today, the ENT scene in India has changed. Wherever I go, wherever I give lectures, when I talk to PGs, I think even Vishwa will agree with me. Now there is a huge gender bias. It is 85-15, 85 ladies and 15 men. Huh? No, basically in a batch of 100 on average, I'm seeing there are 85 ladies and 15 men. So I think slowly we are getting outnumbered. We'll be extinct. A word of advice to the youngsters. See, times have changed. 32 years back, if I had a SN loss after a stapes, it was taken kindly. Or we had occasional facial palsy after mastoid surgery, people didn't overreact to it. The times have changed today. Patients don't take you kindly anymore. As Vedantan said, if a pediatrician or pediatric surgeon can be sued after 20 years, it's no different for ENT. So for the young ENT specialists, men or women, you need to have one particular subject of interest, which is reasonably comfortable to practice, which gives you volume of work to occupy your time. So pick up allergy or pick up sleep or, pick up vertigo. Do your work on that. 6 to 7 years, by the time you can pick up some surgical practice. And as time passes, certain surgeries are going to be extinct also. That is also true. So I think don't sit on saying that I'll be a surgeon, I'll be sitting on the knife's edge and do surgeries morning to evening. You can have many more fulfilling, decent ways of making a living and making a difference to patients' lives. I've had, I think day before yesterday, one patient of mine, I think all of them know in Trustwell Hospital, this patient came, took my measurements, not for the coffin, to stitch 7 pants and shirts for me, because after we did an Epley's maneuver, his vertigo, which was troubling him for 3 years, with all medications, has gone away. So which means there's nothing very masculine or heroic about doing surgeries only. Allergies are going to be increasing. So also the number of cases of vertigo, thanks to obesity, the sleep, and skull-base osteomyelitis, not due to diabetes. So these are areas which the youngsters can focus on, do a lot of work on it, and have a career around that. Thank you very much. I congratulate Lakshmi and the team of Micro who have done this. We plan to come up with a monograph for CSF rhinorrhea in the next 4 months in the form of a book, which contains all the surgical approach, indications, contraindications, everything. This is from Micro Labs initiative. Thank you.
Yeah. Now we have the next speaker, that is Dr. Vishwas Vijaydev, an accomplished facial plastic surgeon from Bangalore. We are very proud to have you, Dr. Vishwas. Yeah, he is very much a Bangalorean. He graduated from Bangalore Medical College and then did his MS ENT from Manipal Medical College. Then he has done his facial plastic fellowship from UK. He has also had his part of his training in USA. His area of special interest includes rhinoplasty, facial lipotransfer, blepharoplasty, facial reanimation surgery, lip and cheek and chin augmentation, auricular reconstruction, and other cosmetic procedures. He has presented his work on nasal aesthetics, facial trauma, local flaps on the face, septal perforation repair, and cleft surgeries at various regional and national conferences across the country. He is the founder and treasurer of Facial Reconstructive and Cosmetic Surgeons of India Trust. Currently, he is a chief consultant, facial plastic surgeon at Trustwell Hospitals, and he's doing extremely well. He keeps on conducting lots of workshops at the national and international level. Recently, he took part in organizing a cadaveric dissection workshop on facial aesthetics, which was very well attended and appreciated, attended by many international faculty also. Over to you, Vishwas. Welcome to you.
Good afternoon, everybody. After a wonderful lecture by Professor Vedantan, I don't know how I'm going to impress upon you the facial plastic branch. Hopefully, you can convert from allergy to facial plastic for the next few minutes. I myself, to be honest with you, I was thinking, why didn't I become an allergy fellow? And I took up facial plastic in the last 1 hour. Probably if I'd spent 3 months with him, maybe I would have been an allergy fellow talking on allergy today. Thank you. And this session especially after tea, I'm sure all of us are wide awake to see what we can do as ENT surgeons and reconstruct or bridge the gap by using the flap. And this day today is dedicated to all you lady ENT surgeons who have been bridging the gap since time immemorial by being surgeons, physicians, wives, mothers, daughters, daughter-in-law, and hats off to all of you. And thanks to Lakshmi ma'am for conducting this wonderful workshop and Dr. Manjula ma'am for making sure everything falls into place. Now, our concept here is something like this army ant bridge. This army ant bridge, if you see, they use each other to cross a certain area of obstacle. And this is how we should all be working, coordinating, building a team, and using each other's help whenever is required. And do you know how the last man goes out? This person wants the last ant, how it goes out? They build a ladder by which they climb on each other. So we always need to make sure the bridging the gap happens between the privileged and the underprivileged, the teacher and the student, the partners. Everybody has to bridge the gap to make sure our patients are much better. So the concept of using the flap is all about skin and its circulation. And what is a flap? A flap is basically a tissue which carries its own blood supply and is attached to the body. Why is it so important? Because it is a reliable source to build a defect. Now, in the outpatient, we do see some of these patients wherein they have been reconstructed, but you can obviously see, do you have a pointer in this? You can see that the reconstruction has been done here. You can see there is no color match. There is a depression. This is seen from a distance, and somebody has sutured and the brow is flying in the air. Somebody has sutured this, there is ectropion. This is not what we want to achieve by suturing together just because we know how to suture. We can use flaps, and face is a special place where the flaps come into use because of the vascularity and because we have lot of adjacent tissue which can be utilized. Now, this is what I was mentioning to you about. There are reservoirs of extra skin in the glabella, temple, preauricular region, nasolabial. All this can be employed to correct the defects in the entire face. One thing to remember for all of us is the relaxed skin tension lines along which you can design your incisions so as to give a better cosmesis. A few basic principles I'll go through, not touching upon too much, is the subunit concept. What it means to say is each zone has a particular type of skin, a texture, a contour, which when handled within that zone gives better results. And that each zone can again be split into various subunits, which are also unique in their own sense. So this is about the choice. Now, always what happens, you have a choice before you to choose the tissue to put into your patient's face. And the choice, obviously, we have a ladder that Dr. Shruti mentioned earlier. It can go from secondary intention to a free tissue transfer, and local flaps and regional flaps come somewhere high up in the ladder. And this is what we want to be using most of the time. The classification of flaps is huge. Just to tell you a few things, it depends upon the vascularity, it depends upon the constituents, contiguity, and the conformation. This is just theoretical, just for your reference. One thing that you need to remember is the method of moving the flap, which I'll explain to you. It's very simple. You either move the flap forward, you either move the flap rotate, or you make the flap jump over. It's very simple. And of course, there are technical terms for it. I'll go through it later. So when you know how to do a flap surgery, so how do you improvise your results? Make sure you keep your knowledge up. Always you should know what would be the best tissue to transfer with regards to the bulk, the contour, the cosmesis, and the match of the tissues. So just to tell you, an advancement flap here, it would be better if I had a pointer. Can you just give me the pointer here? Did you see? No, sir. Thank you. So this is something called as an advancement flap. This is a transposition flap wherein the tissues move from the adjacent area, and in a rotation flap, they stretch across a stretch pressure. So in advancement flap, what happens is it moves along a single vector, whereas in a pivotal flap, like the rotation and the transposition flap, they rotate rather than advance. A hinge flap is something wherein it moves on a three-dimensional plane
into a different area. So without wasting much time, let's go to each subunit and understand how you can employ the flaps in your day-to-day practice. I'll try to make it simple and more interactive, because just giving you information, what I have done doesn't matter at all, because we need to make sure and get the confidence that yes, we can do something about it. So I'll try and ask you your opinion on what you think would be the right tissue to move in there, or from where the tissues can be moved in. So this is a patient having a sidewall melanoma. Obviously, after the excision, there are various ways to reconstruct this. You can put a simple full thickness graft, split skin thickness graft, but the best tissue again here would be a local flap from the nose, because you have enough of extra tissues on the nose, enough of tissues on the nasolabial fold. So what would you choose? Most likely, yeah. So if you're doing the nasolabial fold, what happens is the flap has to jump over onto the area of defect that you can see here. So in that case, that would be called as an interpositional or an interpolated flap, wherein there's a intervening bridge of tissue still intact. So what you could actually do is design the flap in such a way called as the musical note flap. You can see this musical letter note, and this is the musical note flap. You can design it in this manner by excising the tissues in that corner as well and building it. So you remove the tissues of the intervening bridge and make it like a transposition flap or a hinge flap. So this is how the reconstruction will come immediately after 2 weeks. And then this was the photo that the patient sent to me. Obviously, it didn't come back to me after 3 months. Now, you can get hemangiomas on the nose. So there are various ways to handle this, medical as well as surgical, as well as laser, intralesional techniques. Yatish sir is here, so he can tell us more about it. So this patient had a particular problem that whenever he went out in the sun or he had a drink in the evening, it used to swell up and cause a lot of pain. So he requested for a surgery. And now when you remove this entire lesion, you need to reconstruct it. And the best workhorse in a local flap, an interpolated flap, would be, anybody, any guesses? Paramedian forehead flap. Excellent. So the way to design this paramedian forehead flap is try and limit the amount of tissue that you need to contribute or take from above. So you can see here that I've done a cheek advancement so that the amount of recipient tissue is much lesser. Then you measure the defect, go all the way up to the hairline, create a wider base, because you need to come down and rotate it 180 degrees and join it to the tissues at the submass level. Now, this is what happens. You get a pedicle. This has to be divided at 3 to 5 weeks based on whether he's a smoker or not. If he's a smoker or somebody with a compromised vascularity, you divide it and then do an emplasty. And this is how the patient heals. And you can see that it can be uniplanar. Only thing is you need to take care of the scars, because we have type 4 or type 5 skin, because they hyperpigment. So flaps are not all the things that you need to do. There are certain diseases wherein moving the tissue does not help. It does not mean that flap is the answer for everything. So this patient with rhinophyma had something called as a trimodal therapy with excision, laser, and then you can see that we just leave the skin to heal by itself. So if you remember the ladder which I showed you, secondary intention falls last on the ladder, but it does not mean that is always the last. It can also be utilized in various scenarios, and this is how the patient heals just by secondary intention. It need not be that you always need to replace something with something else. The body has an innate capacity to heal, and the nature makes sure it heals quite well. So from here to here, it is possible in 3 months' time. So how do you prepare a patient for surgery? Now, this is the most pertinent question when you're doing anything on the face, because the face shows from a distance and the patient is going to ask you, doctor, you did this scar 20 years back, like the pediatrician who can be sued, even I'll be remembered and noticed. So what we do is minimum of 2 consultations, consent, inform, document, put everything down on paper. Even your worst complication, put it down on paper, put down the percentages, and then only progress with touching the face. And make sure you have your fine set of surgical instruments when you're handling something like the flaps. So this can be LR defects. We do something called as a bilobe flap. The reason to do this is you do not want to move too many tissues from other side. This is how it heals. Frontal view. Again, tip subunit can be handled with a bilobe flap. Sometimes you get this congenital soft triangle defects. And this is something that is challenging. You can either move tissues from somewhere, but being a child, you would want not to create another scar on the face because the child is already scarred. So there is an option called as a composite graft, in which what you could do is take down the skin lining as a vestibular mucosa, and then onto it load a tissue from the ear, which can sit on it and derive its vascularity from there. So this is also a technique which you can use. It heals reasonably. Only thing, the pigmentation needs to be handled. Of course, you can get multiple diseases like neurofibroma, which can be recurrent. You need to completely excise it and do something called as a globular forehead flap, again a transposition flap. So as otolaryngologists, the nose, ear, and the oral cavities are some things that come more often to you. So that's why I'm going to handle the pinna subunit. Post-orally, you can get a lot of lesions. It could be infections, benign tumors, which when removed, there's enough skin on the occipital area, enough skin in the post-oral area to be utilized. Again, you can use a transposition flap here. Make sure you suture it in 2 layers. This is what you need to remember. Always go subcutaneous and then cutaneous. Don't try to just do it in 1 layer, by when your healing will be defective. What would maximum happen is the groove behind would be obliterated. One more case example. You can have trauma to the helical rim. You can use something called as a pedicle flap in the preauricular area and tube it and get a good contour. If you have a patient with an absent ear lobule, you can design something called as a bilobe flap, but you need to make sure that you place a cartilage in between so that the flap that you place does not shrink, and finally you're not left with any ear lobe. This is a common occurrence with many of us after we have done mastoid surgeries. If you have not supported with the muzzle, you can do an advancement flap from the occipital area. Just take care of the hairline. You need to design something called as Burroughs triangle to allow the stretchability. So the way we calculate is whatever the defect, 1 to 2 times is the stretchability to allow the movement. Now, keloids are something that you are seeing all the while, and especially mid-zone. You can do helical advancement by cutting across the helix and moving it further like a C. It closes very well. So what I was telling you all till now is just the superficial part. So there are few basic principles that we have to follow. On the face, we use something called as a vertical mattress suture. Whenever we stitch, we like to see a very level faced skin when we suture. And what actually happens is once the skin starts contracting or the collagen tissues start contracting, it goes inside. And this is what shows from a distance. So try and get your tissues to bunch up when you suture by a vertical mattress suture. And once you remove the sutures, what happens is then it becomes equiplanar. So this is what we would prefer on the face, because any groove will show up as a shadow or a scar later. And some of us have the habit of using our breakfast on the sutures. So we go and tighten the sutures too much. What happens is the tissues in between the sutures die away, and that becomes hyperpigmented, that becomes more scarred. That is where it shows up. So try and do a tension-free closure. If you're operating on the lip, you need to appreciate the margins and the borders very well. So you can give blocks like infraorbital block or mental block rather than infiltrating lignocaine into it. Avoid excessive cauterization. We prefer using the bipolar because the current just flows through a small circuit. And always, always, always identify the different layers: epithelium, subcutaneous, fat, muscle. If you do not identify it, then you will end up showing the scar to a distance. Now I put this photo here because this boy has had a nasolabial flap being taken. Obviously, it has come into the groove, and we have taken bilateral nasolabial flaps to line the premaxillary defect. He had a premaxillary tumor which was 6.5 centimeters, and it has been taken. So if you follow good cosmetic principles, you can manage to give a good outcome. Now, don't always have the confidence or your own skills. The tissues are themselves very good at healing. So this is one of the tissues that one of the patients that came with the ear hanging from its ear lobule. Good thing was he had a granulation tissue, and I did a few microvascular techniques and then moved the local flaps in to provide vascularity. At the end of probably 17 dressings, and this is what came up. So tissues, even if they look very, very fragile, if they have the vascularity, you can still salvage them. Again, this was a crush injury managed by a broad advancement flap. Now, we have all faced keloids and we know it is always recurrent. So you need not depend upon only one flap. This was something that was done by just suturing it primarily. But the keloid principle is whenever you suture something very tight, it comes back again. So you need to have some different approach. So I used something called as a rotation and an island pedicle flap to move the skin across so that the tension is reduced. And now this is how the patient healed. And you can continue your intralesional steroids. And sometimes when you fit a microtia frame, a cartilage frame into the ear, you can get this buttonholing because it is not supported, or if you have thinned the skin too much. This can be handled by a simple transposition flap from the preauricular area, and this is how it heals in the post-op. These are actually rare, the bat and the lop ears and the cup ears. If you have a defect like this, you can be ingenious and try something called as an reverse Z-plasty to extend the ear framework and make sure. These are usually corrected in early childhood by 2-3 years. Now, this is an unfamiliar area, but with practice and with knowledge, you can develop your skills into the eye subunit. Now, this patient came with the meibomian gland carcinoma, and this can be handled by taking tissues from the adjacent lid. So what we did was take tissues from above and below. That is, you take the muzzle from below, transfer it above, conjunctiva from below, transfer it above, and the skin from the adjacent periorbital unit. So you can build the lid. Sometimes you get patients like this who have had road traffic accidents. You need to do multiple surgeries, a skin graft in place, a flap in place, and 3-layer closure, including the tarsus, conjunctiva, everything. And then you can get this kind of closure, provided you are persistent. So in your consent, you need to put down the wordings that there might be multiple sitting, there might be multiple surgeries. You can get patients, especially after this mucor pandemic, many patients who come and tell you that they are breathing through their eyes and producing nasal secretions through their eyes. So you can handle with this with a paramedian forehead flap and close it in 3 layers by something called as a galeal flap as well. So coming on to the forehead subunit, there's a principle called as A to T, wherein after you excise the BCC, you can close the epithelium, rather the dermis and epidermis along the hairline. So very simple principles, but it gives very good cosmesis. Traumatic patients like this who have degloving injury, you can make sure the scarring is minimal by doing simple rotation flaps when you are actually suturing. So what you need to do is always consent the patient for a second surgery after trauma to revise the scars, but during the primary, that is the best chance to give the good scar. So during that also think and suture. Don't just go on suturing because you see 2 tissues coming together. So central forehead squamous cell carcinoma, the lesion looks so small, 1 centimeter margin. You can use bilateral advancement flap. The basic principle is go down to the galea, go down, fully you go down. You will see the frontal branches, you will see the supraorbital branches, make sure you preserve them, then reconstruct them, and it heals quite well if you follow the principles of facial plastic surgery. Nodular BCC of forehead, I was fortunate enough that I could operate this with Lakshmi ma'am, and this was a combination of an advancement flap and a rotation flap, quite a wide lesion. And this is just the post-op, immediate post-op picture. I have not put the late post-op here. Now, the cheek also is something that you will see often, something adjoining the nose. So this is a simple lesion, so it looks like, but once you excise, what happens is you get a circular defect. If you happen to close a circular defect along the nasolabial fold, either your medial eyelid will fall down or your lip will move up. So what you need to do is design something like an extension wherein you remove the pressure on the suture line, do a cheek advancement and close it to get a good approximation. Sometimes you get this kind of patients who are having trauma, especially infraorbital fractures, and a scleral show. That means the lid has caused eversion. You need to revise these scars. The best way to revise a scar or turn the tension is to do a Z-plasty. these are principles of basic facial plastic surgery. Slide is on, not moving. Moving. Oh, sorry. By this, you can handle you can see the plating that has been done here, and yeah, this is how the scleral show can get reduced once you revise the sutures and the scars heal quite well. You want me to use the So why does all these people come to you? Because they dislike scars. It's that they can get it stitched by anybody, but they come to you because they dislike scars. So we need to know that we need to reduce the possibility of a scar by taking maximum attention, not causing asymmetry, making sure they're not raised or depressed, uniplanar, they're not pigmented or pale, by referring to a dermatologist and getting their opinion after the suture removal, and make sure that if there's a hypertrophic tendency, take an early treatment or early intervention. At the same time, whenever you're suturing, make sure that you identify nasolacrimal duct injuries, eye injuries, facial nerve injuries, speech and eating is also not compromised. You also need to understand a thing or two about the skin pigmentation when you counsel the patient. There are a lot of things to for us to talk about, but then we will discuss it later. Now, if you take the lip, a few more units left. If you take the lip, it can be handled by augmentation using a reverse flap from the mucosa, and it can be augmented. This is called as a visual lip deformity, especially for the bilateral lip. Cleft lip can be handled in various ways. You can do a Millard rotation advancement flap, or you can do a Tennyson-Randall flap, triangular flap. They heal quite well because these are basic principles of rotation of the flap, which I explained earlier. Whenever you are suturing on the lip, you need to make sure all the 5 layers are taken care of. That is your inner mucosa, the muscle, the fat, then the subcutaneous tissue, then the skin. If you do not do it properly, this is what happens. The lip becomes thin here. So once you replace the muscle or get the muscle in approximation, you get a bulk of the lip, as well as you replace the hair by hair transplantation and scar revision, you get an approximation in this manner. If you just do an advancement flap alone with the skin, you can get a reasonable result as well. So SEC of lower lip, wide excision, you can do a VY advancement to close it. Of course, there's a disadvantage of microsomia, but then it is a reasonable result. Now, this was a patient we had in the ICU with an immunocompromised state. She had a labionasal and oral fistula. She healed after multiple dressing, and this was the fistula that she had developed. One of my colleagues, she designed a new flap for this, and this is what we call as the ALR advancement flap. And thankfully, it healed well, and we published this work also. So this is a new flap that has been contributed by Dr. Joshna. So basal cell carcinomas are very common on the face, and dermatologists see them very well, very often. They can be handled by simple transposition flap. Scalp subunits. This patient story is unique. He had had 2 surgeries to remove a dermoid, and he didn't want a scar anywhere. So I had to plan and design the scar along the hairline, making sure that he doesn't have any scar. So we did something called as a reverse Z-plasty, wherein we opened the whole thing and then closed it back again, so as to get the scars in alignment. This was almost a 5.5 centimeter dermoid. Thankfully, he was happy with his scars. So oral lesions, of course, this is after a maxillectomy, split maxilla approach. This was reconstructed with the facial artery myomucosal flap. These are all very, very simple principles and straightforward surgeries to learn. So this is not some rocket science. Of course, with cleft palate, again, you're doing rotation advancement. We need to have proper training for that. Basically, cleft palate, to just reiterate a point, it's not about just closure. Once you close the muzzle has to move. Only then your closure is going to be effective. So you need to make sure that your patient receives the speech therapy post-operatively to get a good closure. A few of the free flaps that we did, this was for a recurrent amyloblastoma mandible. You can see the defect from the midline symphysis to the ascending ramus, probably the subcondylar region, and a fibula inset with a monitoring skin paddle. You can see the microvascular artery and the vein combination, and this is the monitoring skin paddle. This is the monitoring skin paddle inside, and she is immediate post-op after 5 days. We also get oroantral fistulas, which can be handled reasonably well with tissues from inside the cheek or inside the palate. So this patient had almost an 8.8 millimeter defect. Whatever she used to eat used to come out through the nose, and all the secretions she used to come out through the mouth. All the time she had halitosis. So you can use dual flap. One is the buccal fat pad flap and then the cheek mucosal flap. The only disadvantage is it obliterates the alveolar sulcus at this point, but it has a very good closure potential. This was a very, very bad tumor infiltrating all the possible fossas. It was almost stage 3. So again, an ALT flap done for it. But hold on, this ALT flap was good for 4 days. On the 5th day, it just clotted. Okay. Usually we see the clotting early in the 3 days, and then we were resting on our laurels and thinking, okay, we are fine. It just clotted and started becoming bluish. Such a big reconstruction, a reasonable good reconstruction can fail. So if you're doing free flaps, you need to be aware for the next 5 to 7 days what is happening with your patient. So failure is something that is well written in surgical textbooks. We need to document it on paper and not carry on our confidence. So we had to salvage it, do a PMMC and a rotation flap from the temporalis. But yes, we do get patients like this. And this was what I think Dr. Shruti was talking about. So what do you do in this patient? We really have no answers. We might be great surgeons, we might be big fellowship holders, whatever we have in our kitty. But we do have something like this, which we have no answers to. Hopefully time will give us these answers. My references are all my patients who taught me and all my teachers before me who taught me their techniques and allowed me to practice on their patients. And very good textbooks are there, which you all will be given or told if you're interested. But this is what I've found most of the time. You only need to find yourself. Rest of it can be found. Thank you. I end my presentation with this man's photo because I believe he bridged the gap between the privileged and the underprivileged. And hopefully with this talk, I can bridge the gap in your minds to make the jump between ENT and facial plastic surgery. Thank you. Thank you for a patient.
Heartiest congratulations, Dr. Vishwas, for a brilliant and out of this world performance and excellent case series. We are really fortunate to have a young and extremely dynamic facial plastic surgeon amongst us. You're really an asset to our community. Wish you all the best, and in the years to come, may you have many of your younger generation get trained by you. Okay, all the best, Indian. Time to call upon Mrs. Sahana Satish, who will be delivering the last lecture of the day. It is something, a non-medical topic. It is health and happiness through mind and meditation. I'm going to give a brief introduction of Sahana Satish. Okay, without wasting much time, I'll be giving a brief introduction about Sahana. Sahana is an industrial engineer by profession. Right now, she's working as a senior product manager at Twilio. She has had 8 years of experience delivering value to her clients, primarily in the supply chain domain. Prior to Twilio, she had worked as a project manager lead in a company called Infor. She has initiated and executed several projects with the aim to drive improvement in end-to-end supply chain visibility for customers. Her role got her the opportunity to interact with global transportation carriers and customers across multiple continents in 3PL manufacturing, automobile, healthcare, and shipping industries, to name a few. Associated with the Art of Living Foundation from the last 13 years, she is a specialized mentor and facilitator for the Happiness Program and online breath and meditation workshops. She is driven by the passion of Sri Sri Ravi Shankar to create a stress-free and violence-free society. Over the last 3 years of the pandemic, she has taught free COVID care yoga and immunity programs to more than 300 people, helping them overcome the physical and mental stress during the pandemic. She has also taught the Art of Living youth programs, which is called S Plus, in various universities, including the her alumni college, BIT, Bangalore Institute of Technology, and the Surana College of Graduation. She is a S Plus program teacher, and it helps instill life skills and human values by creating an environment where every student has the opportunity to develop to their full potential and be prepared for future challenges in the global society. Sahana was the key organizer and driver of the Karnataka Education Conference for Reforms in 2019, held at the Art of Living International Center. The conference brought more than 200 key stakeholders of higher education together who curated reforms in higher education, which were later submitted to the Government of India and took effect as part of the National Education Policy in 2020. She is also a 2.5-year-old toddler, and she's busy managing her motherly activities. Thank you. Over to Sahana. Please take over.
Thank you so much, Dr. Lakshmi. So can we all have, so I know all of you have been listening so far, but for the next half an hour, can we have it an interactive session? Yeah, can we all participate 100%? Yeah. So we all are having different roles and responsibility. We're all wearing hats. You may be running institutions, you may be directors, you may be top doctors, right? But what we'll do for the next 30 minutes, we'll keep that role aside and we'll participate 100%. Can we do that? Yes. Can you say yes 100%? Awesome. Okay. So tell me, so today's topic is health, right? So what is health? How can we define health? Good question, right? To doctors. Huh? Worry-free life. Okay. What else? Well-being, mental and physical. Yeah, spiritual well-being. Wow, wonderful. You know, the founder of Art of Living, Gurudev Sri Sri Ravi Shankar ji says, health is not just a mere absence of disease. Do you agree? It is a dynamic expression of life. Yeah. So, and then what makes us, what are the things that can, make us, take away the happiness from us? Tell me, what takes away your happiness? Worry. Okay. What else? One at a time. Yeah. Okay. If you cannot achieve your goals, then it takes away your happiness. What else? Time limit. Okay. What else? Work-life balance. What else? Stress. Yeah. Wonderful. Huh? Failures. Yes. Wonderful. So, yeah, as ma'am said here, can we put all of this together and call it stress? Yes, one way or the other? Yes or no? Right? So, how can we define stress? Too much demand and less supply. Yes or no? Like too many things to do, but too little energy. Yes or no? Do you agree with me? Right? So, tell me, what are the different ways we can gain energy? What gives you energy? Can you tell me? Sorry? You said prayer? Okay. Exercise? Yes. Food? Yes, of course. Hobbies? Yes. Music? Yes. Sleep? Yes, somebody missed out the most important thing. Yes or no? Right? And we all miss something very, very basic. What is that? Huh? Associations, meditation. What else? Something which we do every moment. What is that? Yes, breathing. Very good. Yeah. So can we put it as 4 different sources of energy? Can we bucket it into 4 buckets? Food, sleep, breath, and a happy meditative state of mind. Yes or no? Music, exercise, all of this, being with our people, what does it do? It gives us a happy meditative state of mind. Yes or no? Don't you think that gives you energy? Yeah. The moment you're tired after a very tiring day, you go back home to see your loved ones. The very thought of it makes you more energized. Yes or no? Yeah. So, but throughout our life, what have we done? We have only focused on food and sleep. Yes or no? Do we ever miss our food? Every 3 hours, our stomach grumbles. Yes or no? We definitely go and have our meal. And every night, we definitely sleep. Yes or no? So, but the most important other two aspects is what we'll cover today, okay? Which is the most ignored ways to gain energy, right? And food and sleep, these are limited sources of energy, right? But breath and happy meditative state of mind, these are the unlimited sources of energy, okay? So ready to explore the other two sources today? Yes? Awesome. So what we'll do is we'll learn a little bit about the mind now, okay? So maybe I can take an example, ma'am with the yellow dress. What's your name? Doctor? Raman. Ramya, okay. So Dr. Ramya, which is your favorite destination? Dream destination? Maldives, okay. So, so imagine Dr. Ramya is in Maldives, okay, with her favorite person in the favorite, in the most beautiful beach, and there's a big, beautiful sunset that's happening, okay, and she's enjoying that moment, right? It's just the best thing that's happening, the perfect moment. But at that moment, Dr. Ramya gets a call and there's some emergency. Can she still enjoy that Maldives? Can you enjoy Maldives that moment? No, right? Why? The quality of our life depends on the state of our mind. Do you agree? Yes or no? The outside situation can be the best, the ideal one. You may be in your dream destination, but if your mental state of mind is not good, then you cannot enjoy what is outside also. Yes or no? Agree? Okay. Then we'll take some last benchers. Ma'am with the red chudidar. Yourself, yeah. Your name? Dr. Rajini. Okay. So Dr. Rajini, can you please stand up if you don't mind? Yeah, thank you. So you have such a beautiful smile. Wow. That hairstyle, it's so good. That, earrings of yours. Wow, matching. Yeah. Amazing, beautiful, your face cut is so wow. You're like a style queen for today. But that nose of yours, there's something about it, some pachkofied thing there on the nose. Sorry, okay, this is an example. Please sit down. Okay, so what happens now to Dr. Rajini? What will she do the moment she goes out of this room? She will go and see the mirror. Yeah. What is wrong with my nose? Yeah. How dare she talk about my nose? Has she seen her nose or not? Yes or no? Will she think that? Yes or no? Huh? How dare she talk about my nose? Yeah. So what happened now? Right? I gave 10 compliments, but 1 insult. But what does the mind hold on to? 1 insult. Do you see this happening in your life also? Yeah. 10 years of good friendship, but 1 fight. What does the mind remember or cling on to? 1 fight. Yes or no? We spoil relationships like this. We break up relationships, right? We have such difficult moments with our people whom we care and love. Yes or no? Right? So these are the different tendencies of the mind. Let's start becoming more and more aware of it. The tendency of the mind is to cling to the negatives, right? Now we'll also talk about another tendency of the mind. So imagine that this session is over today and you're going back home. Okay, maybe you're driving your car. So what are the different types of thoughts that come to you? Tell me. Okay. Yeah. So maybe you'll think, okay, what should I have for dinner? Should I cook something? Or maybe you'll think about tomorrow, right? If you have a child, maybe what should I pack for the breakfast, or, pack lunch box for? Or you might also thought, if you have given a presentation today, how did that go? Or you start thinking about what all happened throughout the day. Yes or no? So what is happening here? So the mind is oscillating between the past and future. Do you see this? Yes or no? So what is the emotion that comes up when you think about the past? Tell me. Regret. Who said that? Wow, big round of applause. Yeah. Predominantly it is regret. Yeah. So for example, I'm going to take example of my mother. So she will go back 40 years and say, oh, I wish I had done engineering. Even though she's a very successful doctor today, she has that regret. Why? What is the emotion that comes up when she goes back to the past? Regret. Yes or no? So sadness, regret. So all these are emotions associated with the past. And what is the emotion associated with the future? You think about something, anxiety, expectations, very good, amazing, right? So when you think about, okay, what's going to happen 5 years from now? Am I going to be healthy? Will I get COVID? Will this pandemic end? What happens? So don't you see this happening? So this is what happens when we think about the future, anxiety, fear. These are the predominant emotions of the future, right? So where is life? Now, present moment. Yeah. So where is happiness? Is it in the past or future? Present moment. Do you see this? Have you observed a small child? So I talk about children because I have a toddler. Have you seen how they enjoy the present moment? You see my daughter, you give her a cake, she'll say, happy birthday to me. She'll sing for herself and she'll have all the cake all over her face. No, that is present moment. That is 100%. You see, even if they cry 100%. You see this? If you just show them the fan nodu magu anta hedre saku, the tear will stop there only. Yes or no? Right? That is 100%. That is being in the present moment. Right? In the present moment, there is joy, happiness, enthusiasm, you know, efficiency, productivity, right? All that you can achieve. And the secret of time management is to live more and more in the present moment. Do you see this? We waste so much energy thinking about the past and future, right? So is it a good idea to live in the present moment? Yes, but okay, how to implement this good idea? What do we use? We'll use a tool which brings the mind to the present moment. There's one thing I can do now. Okay, so let's all close our eyes quickly. Okay, now imagine yourself in a beautiful park, maybe like Lal Bagh, lots of trees. And on a big banyan tree, there is one pink-faced monkey jumping from one tree to the other tree. Now think you can see anything in your eyes with your eyes closed except that pink monkey with jumping from one banyan tree to the other banyan tree. Think about anything else except that monkey eating the banana and jumping. Okay, now you open your eyes. What did you see? Bye. So what you resist, persist. I'll say don't think about that, then you'll think about that. Yes or no? Now, if you want to not think about, suppose I don't like Lakshmi. Okay, I don't like Lakshmi. I don't want to think about Lakshmi. I don't want to think about, will I get a good sleep? No, right? Why? What am I doing? I'm thinking about her. Yes or no? This is what we do most of the times. Yes or no? Right? So, coming to the point, how do we live in life in the present moment? What we do we do every moment? Tell me. Yes. Can we breathe for yesterday? Okay, I'm so tired today. I'm just going to finish breathing for the rest of the week today only. Can I do that? No, right? Or can I breathe for Dr. Manjula? Dr. Manjula, today I'm very tired. Can you breathe for me? So we breathe every moment we are breathing. But do we hardly realize we are breathing? No, right? It's the most ignored source of energy, right? When do we remember we are breathing? Lack of it during COVID, especially, right? And then when we have a cold, or all ENT doctors, you know, right? People have a cold, then oh, I'm having difficulty to breathe. Yes or no? Or when you're running to catch a bus, you're panting, then you remember you're breathing. Yes or no? So, but most awareness, taking our awareness on the breath, right? Every day can help us to remove so much toxins from the body. Did you know that 70% of the toxins can be removed through the breath? Right? Only 30% is removed through excretion, sweat, and all that. And breathing is a there's a secret to breathing and emotions. Okay, so sir, can you tell me how is your breath when you're angry? Huh? Increases, right? Fast breathing. Yes or no? How dare you, right? We're breathing so fast. And how is your breath, ma'am, when you're sad? Slower, but your outgoing breath is more prominent. Have you noticed? Your outgoing breath is more prominent. And how is your breath when you are happy? Ma'am, green shirt. Slow, long and deep breaths. Yes or no? Right? So do you agree that for every emotion, there's an associated breathing pattern? Agree? Yes or no? Yes. Are you awake in the moment? Or already your mind has gone to the food? Okay. So every emotion has a corresponding breathing pattern. So when we want to fix our emotions, suppose you're feeling overwhelming emotions, sad, upset, angry, depressed, then instead of not wanting that mentally, like the monkey example, right? I don't want to feel depressed. I don't want to feel depressed. Will you be able to deal it that way? No, right? So what is a better way to deal with it? Focus on your breath. Because when you focus on your breath, automatically your mind comes to the present moment, because we're breathing every moment. Breath is always in the present moment. And when we breathe right, we can handle our emotions better. Yeah. And it's like the kite, there's a mind which goes everywhere, and we have the string, which is the breath, right? So we can control, and the body is our body. So we can control the mind through the breath. Interesting. So would you like to experience a breathing technique today? Learn to gain more energy with this breathing technique? Yes, no? Okay. So we'll do a breathing technique now called Bhastrika. So I'll teach all of you. We can all sit in your chairs in a relaxed way. We'll do that followed by a guided meditation. Okay. So I'll explain. So how many of you have done meditation before? Okay, wonderful. So you may have been associated with any other organization or done meditation before. You may have some concepts, right? So, but what is meditation? Meditation is not concentration. A lot of people have this myth, right? That I need to focus on some object and when I'm closing my eyes, or I have to imagine a green light. No, you don't have to do all that. Okay. All you need to do is simply close your eyes and relax. Allow the thoughts to come. It's like the clouds, they come and go, right? Simply observe, listen to the instructions and simply relax. That's the only instruction. And concentration is a result of meditation. Yeah. So shall we do that today? Okay. Let's all sit easily and comfortably. Okay. So we learn something called as Bhastrika Pranayam. Okay. How we do that is, hold your hands. Okay. Yeah. So we'll have loose fists in front of the shoulders. Okay. Loose fists in front of the shoulders. And as you breathe in, you just observe first. Don't do. Okay. So as you breathe in, your hands go up and fists open. Okay. And as you breathe out forcefully and your fists come here. Okay. Easy with both hands. And you can maybe keep a handkerchief. You may get some things from your nose. It's common. Okay. It's allowed. Don't feel embarrassed about it. You can have a handkerchief and throw it out. Let's do it 100%. Okay. We'll do 3 rounds of Bhastrika. Okay. We'll do 10 each. And in between, when I say relax, you can just keep your palms on the lap facing the sky. Okay. And relax. Okay. Ready, everybody? Okay. Let's keep our eyes closed. Let's get ready for first round of Bhastrika. Loose fists in front of the shoulders. Eyes closed. So let's take position for Bhastrika. Take a normal breath in and breathe out. For Bhastrika, with force and enthusiasm, breathe in, hands go up, out, forcefully down, in, out, continue, in, out, continue. Very good, continue. In, out, in, out, in, out, in, out, in, out. Relax, palms on the lap, facing the sky. Observe the sensations in your body. Feel the flow of energy in the body. ಶರೀರದಲ್ಲಿ ಶಕ್ತಿಯ ಸಂಚಾರವನ್ನು ಗಮನಿಸಿ. Let's get ready for the second round of Bhastrika. Loose fists in front of the shoulders. Take a normal breath in and breathe out. With a smile, take a deep breath in and breathe out. For Bhastrika, with force and enthusiasm, breathe in, hands go up, out, in, 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 out, and relax. Palms on the lap, facing the sky. Observe the sensations in your body. Feel the flow of prana in the body. Let's get ready for the third and final round of Bhastrika. Loose fists in front of the shoulders. Take a normal breath in and breathe out. For Bhastrika, with force and enthusiasm, breathe in. Hands go up, fists open, out, in, 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 out, and relax. Palms on the lap, facing the sky. Observe the flow of energy in the body. Let's sit easily and comfortably with our eyes closed. We'll now do a guided meditation. Let's keep a gentle smile on the face and take a deep breath in and breathe out with a bigger smile. Let's become aware of all the sounds and noises in the surroundings. ಸುತ್ತಮುತ್ತಲು ವಾತಾವರಣದಲ್ಲಿ ಆಗುತ್ತಿರುವ ಶಬ್ದಗಳ ಕಡೆ ಗಮನವನ್ನು ಹರಿಸೋಣ. Accept all the sounds. Sound of the fan, sound of birds chirping, people talking. Let's accept all the sounds. Take a deep breath in and breathe out. Let's become aware of our body. Our body is a precious gift to us from nature. Let's honor and respect our body. Let's place the entire weight of the body on the seat we are sitting and relax completely. With a smile, take a deep breath in and breathe out. Let's become aware of our breath. Incoming breath energizes the body. And outgoing breath relaxes the body. Let's become aware of every breath in and out. Let's become aware of our thoughts. Good thoughts or bad thoughts, let it be. Accept all the thoughts. Let's become aware of our emotions. Happy or sad. Patient or impatient. Accept all the emotions this moment. Be with it 100%. Deep breath in and breathe out. Relax more and more. For the next few minutes, I want nothing. I am nothing. And I do nothing. Relax more and more. Lokha samastha sukhino bhavantu. Loka samastha sukhino bhavantu. Loka samastha sukhino bhavantu. Om Shanti Shanti Shanti. Slowly become aware of your emotions, if any, thoughts, if any. Let's take our attention to the breath. Slowly become aware of your body and surroundings. Slowly and gradually, as and when you feel complete, with a smile, we can open our eyes. Good. How do you feel now? No? Anybody wants to share your experience? Okay, so we can show the QR code on the screen. Yeah. So what you experienced now is just the tip of the iceberg. Yeah. Would you like to know the other technique that we teach in the Art of Living programs? It's called Sudarshan Kriya. It's a very, very intense, powerful breathing technique. And I invite all of you to come and experience it. Yeah? In this lifetime, at least, you should do it. Yeah, when we have this body, you have to experience Sudarshan Kriya. It helps to remove all the toxins from our body. It makes us more light, fresh, alive. Just like we take bath every day, or like just like dental hygiene. And this is mental hygiene. Huh? So don't you think it's important that we take our attention to the mind also and breath for our well-being, health and happiness? Yes, do you agree? Okay, so then you must invest your time on learning Sudarshan Kriya. Would you like to learn? Yes. So can you just fill a feedback form? You can all take out your mobile phones, open the camera. Can we all do that for a moment? Let's all remove mobile phone, open the camera and scan the QR code on the screen. Did it scan from a distance? Dad? No, Dad, and the last row. Okay, click on the link once you scan. You might get a link. Just click on that, you'll get a feedback form. Go to the camera. Just scan that, like take an image, photo. Dad, banta nahi hai. Did you get it? You didn't get it? How many of you have not got it? Maybe you can just come forward and take a scan. No, just directly on your camera. Yeah, got it? Yeah, you have to just open your camera, mobile phone camera, and take a photo and click on the link and fill the form. Submit your form. Amma, you got it? Banta feedback form. Click on it. Fill it. If anyone's still struggling, please raise your hand. We can help you out. Aita, yare gotaktala kai etti. Okay, please submit your response. Okay, done. Everybody? You didn't get it? Can you just come close and take a photo? So you might get a link, right? Actually, you don't even have to take a photo. You might just have to show it, right? Does people have to just show it? Show the camera. Focus the camera on the QR code. Yeah, you need internet, not Wi-Fi, internet. Airtel or Vodafone or whatever, data. Data should be on. Done? Okay. All right then. Nim groups idre group al kalispad. Yeah. So if you're not able to do it, you'll get the same QR code on your WhatsApp group. But then how will you scan it? You'll use some other phone and scan it. Okay. Or yeah, you can a link kalside like bit dot. No, the bit link is there. Yeah, please, the bit link, you can fill your feedback. Okay. Thank you, everybody. It was a great session. I hope you enjoyed. Okay. Anybody wants to share your experience quickly? Okay, great. Okay, wonderful. Wonderful. Okay, wonderful. Wonderful. Yeah, any questions? Please.
So, well, usually we keep on watching movies and all that. Then I was coming nearer to Bangalore. There was only half an hour left. There was one meditation thing. So let me do this. It was a very, very simple technique in it. He said, why don't you just close your eyes, and as thoughts come, you say you to yourself, I don't know, I don't want to know. That is all for everything. I know, I don't know, I don't want to know.
Okay.
So I kept on repeating that to any of the things happening. And then things started really quietening down. It was a very simple technique. And I felt very relaxed and aram. But can you please comment on such a technique?
I cannot comment on other organizations, but
No, it is
definitely.
no organization there. It was just a suggestion. I
Mhm.
don't know, I don't want to know. Those are the only two questions that you have to ask.
Yeah, so here also, if you notice, I gave a instruction, right? I want nothing, I do nothing, and I am nothing, right? So it's similar to that. But meditation is going beyond intellect also, right? So in intellect, in the case of yours, you have to keep giving some exercise to your intellect, saying whatever you have to say, right? But in this case, you just relax simply without even giving that exercise to the intellect. So you go beyond the intellect. Okay. Yeah. And it's always good to learn meditation under the guidance of a teacher or a guru rather than just Googling it. Yeah. Because most of the distraction happens with the five senses. Do you see this? When immediately we see something, we see the person next to us and we get some thoughts. Yes or no? Yeah, when you open, if you open your eyes, that's definitely you can meditate with eyes open, but there's a little advanced stage. As beginners, we can start with eyes closed. As we move ahead, then every moment is a meditation. You can be meditative when you're walking, talking, sleeping, eating, everything. Huh? Okay. Any other questions? How to? During meditation?
My son has a big problem of doing meditation. In the class and all, they will teach him, but he never does. He says, I feel sleepy.
How old is he?
He is 12-year-old.
Yeah.
Yes, sir.
I would suggest your son attends the Art of Living program for the age group of 18 to 13-year-old, 8 to 13-year-olds. There they teach in very fun and interactive games, and there's lots of things to enjoy and look forward to. And once he starts enjoying it, he'll start doing it. Okay. Okay. Any other questions? All right, then I think it's getting late for lunch. Thank you.
So thanks a lot, Sahana, for a wonderful session. She has been introduced into the art of living from the age of 13 years. Okay, so she is very passionate about it. Thank you for the wonderful session. Now it's Dr. Manjula will take over.
May I now request all our faculty to come and ask Dr. Maitri ma'am, Dr. Vishal, Dr. Deepak sir. Sir, please, you must come, sir, please. Madam Bani, Sahana, sir, Vedantam, sir, please come on the dais, sir. Separate. Sir, name first.
Hello. You reach all 60 years and then what you do on Sundays, yargo topi hakodu. ಆತ್ಮವಿಶ್ವಾಸ ಅಂದ್ರೆ ವೇದಾಂತಂಗೆ ವೇದಾಂತ ಹೇಳ್ಕೊಡೋದು. ಮೈಕ್ರೋ ಲ್ಯಾಬ್ಸ್ ಅವ್ರಿಗೆ ಒಂದು ಸಲಹೆ, ಈ ಪೇಟಾಗಳು ಶಾಲೆಗಳು ಎಲ್ಲಿಡೋದು ನಮ್ಗೆ ಗೊತ್ತಿಲ್ಲ. ಮುಂದಿನ ಸಲಿಯಿಂದ ಇದೇ ಖರ್ಚಲ್ಲಿ 3 ಹಣ್ಣಿನ ಬುಟ್ಟಿ ಕೊಟ್ಬಿಟ್ರೆ ಒಂದ್ರ ಬದಲು ಅದೇ ಜಾಸ್ತಿ ಉಪಯೋಗ ಆಗುತ್ತೆ.
Thank you so much, Vedantam sir. It was wonderful to have you. And people were asking online, there were more than 200 registration. They were asking to continue for more your time. Then we didn't have, next time we'll have a long session. So we had a live streaming of
Vishwas.
this, also. No.
Good thing you didn't tell me about life.
I
was totally aware. This has been incredibly pleasant surprise, Dr. Lakshmi and Dr. Manjula. You are good in keeping secrets. And it has been a wonderful experience, very hard to meditate now. And very positive. The thing about it is, what I like is people who would like to learn. And that actually acts as a stimulus who wants to share the, I don't use the word teach. I want to share the information because I want to learn from you also. So it has been a wonderful experience for me. Thanks to the micro labs and to Dr. Lakshmi, Dr. Manjula, my dear old friend who is always keeps everybody smiling and engaged. And thank you for the audience, and thanks for the good food, and also to my wife, to Kamala Madam, to keep me going, because she has been a wonderful support for me. Because somebody asked me, sir, how is it, sir? You are always smiling and oh,
Madam, please come.
Madam.
Take one.
Namaste. Namaste.
Welcome,
Namaste,
Bharti
madam.
ma'am. Wonderful to have you.
Oh, haga.
Very
Bani kutkolli.
Come, Bharti, please sit down.
Thank you.
Thank you, sir. ಒಂದು ನಿಮಿಷ ಒಬ್ಬೊಬ್ರಿಗಾಗಿ.
She deserves to be the first woman vice president of the SARC ENT Association.
Oh, great. Congratulations. ma'am.
She walks in just before her felicitation is there. You can't get a better politician than this. Yeah, Lakshmi is felicitating her. Bharti is my classmate. Comes from a very, very humble beginning.
Thank you so much. I know all this is bad.
I don't know Bharti for a long time, because compared to Lakshmi, whom I know from, I think, 1975, I know Bharti from 1980 August. I always used to tell Lakshmi that, you know, our children, the newer generation, are far more mature than us at that age, that what we were. Today, when I met Lakshmi's daughter and Lakshmi, I'm convinced that my theory and this thing is true. That girl was amazing today. Coming to Dr. Bharti, you can see her here. She's not 6 foot tall. She doesn't have a booming voice. But believe me, she has lots of guts. I have known her from my first MBBS dissection days. She comes from very humble beginning. I know that from, this Taralbalu hostel, she studied and came up in ENT. One of the few ones to do MS as well as DNB together. Always a good student. And most of the parents would always say, Adre Bharti tara agbaku, Deepak tara agbardu. And great friend. I derive my inspiration from her. So much of work she has done, academician, and I'm so happy now that she's the president of our association. And I repeat again, the first ever lady president, vice president of SARC ENT Association. And I'm sure she's going to bring IFOS to India next, because this time it is in Dubai. I'm almost nearly 100% confident in her tenure, she'll bring it to India. And they always say, Sunil Gavaskar and Tendulkar always used to say, life is all about timing. Look at the way she walked in, and here we are fell steady. Thank you so much, Bharti, for making this day special.
Thank you, everyone. Sorry, I'm very late for this. Deepak and Lakshmi are my friends from my post-graduation, Deepak from my undergraduation. Like we are all, you call it as study friends or whatever it is. So we grew together and we know each other for a long time of, I think, 3 decades, 42 years. So he has to tell something good about me. Otherwise, afterwards, I'll go and tell his parents. So I know. Oh, yeah, Nandu. So this is it. But anyhow, I'm again sorry for the delay because I had some other work and I had to rush here. And whatever it is, it's, after a long gap, it's Deepak who put Karnataka on map again in the Association of Otolaryngologists of India nationally. So we are very proud of it. And then onwards it went on well, and we want to put Karnataka on a big scale in the national and international level. That is all when I went to Mysore, everyone asked why you are doing all this conference. I just wanted Mysore to be highlighted. That's all. It's not anything for me, no gain for me. It's what I wanted, where I work, where the place which gives me something in my life, I should give it back to the society. That's all I wanted. So somehow the institute where I work, JSS, gave me everything, the shelter, the management was with me in all my endeavors, whatever I did in the last 3 decades. So with their support, I could achieve. We have done 2 national conferences, many CMAs, workshops, state conference, South Zone, everything. So it's all the support what we have. And recently when I went to Nepal, they had a session called Women in ENT. So without asking me, they put me there in the panel discussion. Then they asked how you, I said, nothing. It's you just work, be academically good, you work, the people surrounding you will support. Actually, I told them it's my friends who made me forefront. I was nothing. I just used to work in Mysore, that's all. It's friends like Deepak and others and Lakshmi. Actually, the inspirational factor is Lakshmi. And she has done 2 courses now, really. Actually, for me to study at this, I cannot open my books also. But she has done 2 courses, facioplastic and allergic. It's very nice, Lakshmi. And like this, I think we'll work together to put our association forefront. And I thank Microlabs for their support, for all the supports we had in all our conferences and workshop. They're supported very well. And we wish the support will be there in future also for all our endeavors. And I think 2024 National Conference, again, it will be in Bangalore. And it's a huge conference because it's a platinum celebration of our association. So Dr. Deepak, Dr. Vishwas, and me and other colleagues of ENT in Bangalore are organizing it. So we want all supports from everyone. Thank you, one and all. Thank you, Dr.
Thank you so much,
Manjunath.
ma'am. Thanks. I may now request Dr. Vishwas sir to please accept. Please, sir. Sir, ಎಲ್ಲರಿಗೂ teachers. Dr. Satish, sir, please come.
ಅವ್ನಿಗೆ ಹೇಗಿದ್ರು ಸಂಕೋಚ ನಾವು ಮಾಡಿದ್ರೆ ನೀವೇ ಮಾಡಿ. In fact, Vishwa chose facial plastic over routine ENT. It's been my loss. Because if he had chosen routine ENT, he would have succeeded me in everything. Now he has superseded me and gone ahead. And I thank Dr. Satish, one of the leading dermatologists of the country, having honored him. Thank you so much. Satish or
Madam.
See, whatever we want to achieve, we have to learn from Dr. Vishwas. Because when we met, when he finished his MS and he came, he just wanted to be in one field like facial plastic. At that time, it was not at all established in this part of the world. He said, no, I'll continue with that. And with that goal in mind, that zeal, what he had to conquer that, really he went ahead, and 1 decade of his work is now showing all the flowers or fruits or whatever it is, it's blooming. So he has made his name nationally and internationally. We are very proud of you, Dr. Vishwas.
He's getting restless. Both. Yeah. Yeah. Now it's time to honor our guest of honor. Bunny, sir.
I think Dr. Deepak doesn't need any introduction. He himself, when he comes inside, everyone turns around. Actually, to be just to quote an example, me and the were traveling back from Calcutta early morning. It was just 4 o'clock, and we were in the airport, and just all were sitting, and we didn't have place. So we were just standing, and one person got up and he gave him the seat. We don't know who he is. He said, "You people both sit." Then, that's the thing with which he walks around. That comes only when you are, full in yourself, be it be family life or the academics or the professional life. So if at all you're full in yourself, that glow what you carry on your face everywhere you walk around will make everyone, like the person might not know you, but they'll respect you. And another thing is, whenever we have, he always carries the positive attitude in himself. And whatever it is, you just call him any time of the day. The moment you hear his voice, whatever problem you have, you'll forget. You'll not tell him your problem, but automatically that problem takes a side and it goes off. Yeah, correct. He knows what. So this is Dr. Deepak.
One more thing. I know Dr. Deepak for maybe 2 decades, maybe. You know, they always say somebody has a good personality. He not only has a good personality, he has the most well-rounded personality. He appeals to anyone from 3-year-old to 80-year-old in the same way and keeps everybody happy around him. What do you think, Mrs. Deepak? Kaiwan, what do you say? Do you agree? If you don't agree, you'll be in trouble. You'll be. Anyway, thank you very much, sir. It has been a pleasure to put topi on you, and thank you. Yes, thank you, and thanks, Doctor. I sort of barged in because I could not resist not doing this token of respect to Dr. Deepak, and thank you so much.
Now I call upon Sahana to occupy the chair. Madam Kamala Vedantan, can you please felicitate Sahana? Kutko, madam. Kutko, one nimsha, ಏನಆಗಲ್ಲ. Veena, you can come. Come.
Pratibha, please come.
Pratibha. Nandita. You can also. Bani. Give a. Okay. ಈ ಕಡೆ ತಿಳ್ಕೊಳ್ಳಿ ಕ್ಯಾಮ್ರಾ ಇದೆ ಅಲ್ಲಿ ಫೋಟೋ ಮೇಡಮ್
From our side.
Yeah,
You
picture.
want to, later on you can give it to her.
Nandita ಕೈಲೇ ಕೊಡ್ಸ್ಬೇಕು. ಇವರು ಓಕೆ ಟು ಮೇಡಮ್ ವೇದಾಂತ ಮೇಡಮ್ ಅಲ್ಲೇ ಇರಿ ಕೈಂಡ್ಲಿ ಹ್ಯಾಂಡ್ ಓವರ್.
Dr. Tara madam, can you come to
Thank you so much. I don't
You
need
must,
it.
you are the
No,
inspiration,
no,
you are the mentor, you are the actually creator of this forum, please. Madam, please come. Thank you. I thank each one of you. And can we have one group photo, please? One, all. Hey, ಇಲ್ಲ madam. Hey, ಸರಿ ಇಲ್ಲ.
Rajini, Vimaya. Rajini.
Rajni's nose looks quite wrong.
Thank you. We just take one group photo, then please join us. Post lunch, we have a very exciting activity, fun and frolic games. The person is breaking. Please
I request Dr. Kamala Vedanta ma'am to come. Ma'am, it was so wonderful. Illa madam, it was so wonderful. And that the singing what you did, even with a short notice, it broke all the vigna which were there actually and gave really a nice beginning. Thank you so much. Sir, Vedantam sir, please come.
Wonderful. Thank you so much for coming in, madam.
Yeah, sir, 20, sir. So I would like to give a formal vote of thanks. Thanks very much. And I would like to first thank Dr. Vedantam sir for having taken time off his busy schedule, even though he's with a short visit to India. He's taken time for us and given a wonderful session. And sir, thank you very much for such a nice session. And next session was Dr. Shruti Merva. Madam, it was wonderful. You guided them what to take, how to choose, and what to read also. Though we didn't have you physically, but it was wonderful program, ma'am. Thank you so much for joining in and accepting it to be here. Thank you so much. Then we had session for Dr. Vishwas sir. Again, another wonderful session, very clear and showed us all the things, how he made all women beautiful with whatever they came in. It was really wonderful, sir. Thank you so much. Listening to you as usual. And then Sahanas, Dr. B. Sahana, you made us really relax and helped us what we were doing wrong, running like a rat race, running around, and you made us relax for that time. Definitely we'll follow it and then join the courses which you have told. And above all, I must thank Dr. Deepak sir for coming in, staying with us. And really, sir, you made the difference to us today. It was wonderful. And madam, thanks for joining in with sir. And yeah, big thanks to Lakshmi man for conceptualizing, guiding, and making the program, everything she took, and then made a scientific, extraordinary scientific session, man, as usual. Thank you very much. And last but definitely not the least, I thank all this wonderful audience who made it on a Sunday, came all the way, made it so interactive. Without you, the session would not have been so lively. And thank you very much. And I request all of you, this is the fourth one. Please give us, we want to expand this Bangalore ENT Forum to next level. Please tell us what else we can do scientifically, and then we can take it up. And then you can post it on a group, or you can send me mail so we can have some other additional educational activity. Thank you so much. Thank you one and all. Thanks to all that IT team, helped in transmission, our marketing team and sales team. And so Mr. Avinash is waiting for you all outside for some fun-filled activity post-lunch. Please don't go away. Really, you will have real fun. Since we know Avinash, how he does, please join us for a lunch and one group photo outside. Thank you so much. Thank you and namaste to all.